definitely have to know these two terms. They're going to come up for us constantly, which is oligohydramnios and polyhydramnios. Oligohydramnios is going to be too little fluid. So it's an abnormally small amount of fluid. You have to know your causes of both of these. So things that can cause less amniotic fluid is going to be poor placental blood flow. Preterm rupture of membranes, right? If the membranes rupture, obviously there's going to be too little fluid in there. A big one is failure of the development of the kidneys in the baby, right? We said that most of the fluid is urine. So if there's something wrong with the baby's kidneys that it can't produce urine, we're going to see oligohydramnios.
That makes sense.
Anything having to do with like that system, right? A blocked urinary path, right? Cause less fluid. Even pulmonary hypoplasia has to do with oxygenation and just kind of not allowing that whole system to function. Polyhydramnios is too much fluid. Causes of that: imbalanced water exchange, poorly controlled maternal diabetes, CNS GI tract malformations, chromosomal abnormalities. So we see this a lot with our trisomies, like Down syndrome. And then multifetal gestation, meaning more than one baby, which makes sense, right? If we have two babies making fluid, maybe too much fluid for us in that one sac. So our fetal circulation, right? We have the placenta, but it means nothing to us if it's not attached to the baby, right? So the umbilical cord is going to be another important part of this, right? The umbilical cord, this is actually really pretty accurate, right? If you've seen the real one, looks like this, right? It's the thing that's attached to the baby's belly button, right? We cut it at birth, and then they have that little stump that kind of has to dry off and fall off. No AVA, right? So in our umbilical cord, we need to have 2 arteries and 1 vein, right? So AVA, 2 arteries, 1 vein. If we have a 2-vessel cord, right, so if you see at a delivery, people should be looking at the end where they cut to count the arteries in the vein. If we only have 2, we have 1 artery, 1 vein, we want that baby to be looked at. It could be some kind of genetic problem, chromosomal thing that we don't know about. We just kind of need to look. Sometimes it's actually really just nothing, like it didn't harm the baby, but it can be a sign of some kind of anomaly, so we would need to look into that further. The umbilical cord is covered in this Wharton's jelly, which is this white squishy stuff. And it's kind of like this rubbery. The whole purpose of that is just to protect the arteries in the vein. So chapter 6, very important chapter. This is all about the body changes that have to happen in mom that are going to happen during this pregnancy. Right, like I've said before, the pregnant body is very different than any other type of body you've ever learned about. Things that are normal in a pregnant body, if you saw those same results on a regular person, you'd be horrified. But the body really goes through a lot of changes to maintain a pregnancy. So one of the biggest changes that's going to happen, right, is the uterus is going to grow, right? The uterus has to grow as the baby grows to accommodate a whole baby. This growth is going to be very predictable. So much so that we can literally say at 12 weeks, at that top of the uterus, the fundus, is going to be at the symphysis pubis. At 16 weeks, it's going to be between that and the belly button. 20 weeks, it should be at the belly button. By 36 weeks, it's all the way up at the xiphoid process, right? So it's very high up. And that's when mom's going to start feeling like she's having trouble breathing, right? Because that baby's kind of feels like they're right on her lungs, because they essentially are. So like I said, because it's predictable, let's say a patient comes in and they are 20 weeks pregnant and we feel the top of the uterus and it's, let's say, at like the pubic bone, we would be very concerned. Like that's not normal, right? So they do like a fundal height usually at every visit, just to make sure that the amount of weeks is matching up with where the uterus is. If we see that it's not lining up, it's falling behind, we're worried about some kind of like growth restriction of the baby. There's some reason why that baby's now not growing, and that therefore that uterus isn't growing. So by 40 weeks, right, so 36 weeks, it's all the way up in the xiphoid process. Mom feels like she can't breathe. The good news is that sometime in those last few weeks, she's going to experience lightening. Lightening is the descent of the fetal head into the into the pelvic cavity, right? So the baby drops, right? We've probably heard that, right? If you're hearing anyone talk to a pregnant person, like, oh, you really dropped. That baby must be coming. You really dropped. It's lightening, right? So the baby all of a sudden just, you know, realizes like, oh, I got to start making my way out of here. They drop, and mom will experience lightening. Lightening generally then makes mom feel like she can breathe better because the baby kind of is off the lungs a little bit, but it is going to cause frequent urination because now the baby is right on her bladder, and then tends to cause like pain in her legs because it's just kind of now cutting off all that circulation to the lower body. Braxton Hicks contractions, so all these kind of highlighted things, or you know, things that are bolded, you need to know all this vocabulary. Braxton Hicks contractions. These are contractions that are going to happen throughout the pregnancy. They're like practice contractions, right? So throughout the pregnancy, the uterus, we're asking the uterus to really kind of stretch and grow, and mom may experience some contractions, which is normal.
Is it true that dehydration can bring Braxton Hicks?
Yeah. So just know that they are practice contractions. They do happen throughout pregnancy, but mom may not notice them until the end, until she's getting closer. But know that just because she doesn't feel them till the end, they're happening throughout. Right? That uterus is just getting used to what's going on here. Going into the summer, we know triage is going to be full of patients coming in with Braxton Hicks contractions because it's hot, they're not drinking their water, they get dehydrated, that uterus is dehydrated, and it will start contracting. The other thing to know about Braxton Hicks contractions is that they're not considered real labor. They're false labor contractions. Make sure you're always looking at the notes on the bottom of the slide. I think you have to download them in order to see the notes. Know that Braxton Hicks contractions are not going to cause cervical change. Right? So if mom is only having these false labor contractions, the way we're going to know that they're real contractions versus Braxton Hicks is that cervix is not going to dilate. She was 1 centimeter before, she's having Braxton Hicks contractions for 2 hours. After 2 hours, she's still at 1. Real contractions will dilate the cervix.
Okay.
So you don't know if it's a real contraction until they check you?
Right. The only way to really know if a patient is in labor is to check for progressive
dilation of
dilation.
the contractions will
So
dilate.
you typically get those fake
Dilate the
like
cervix. I can spell dilate. Okay.
Yes,
Thanks.
but know that mom will be getting them throughout the whole pregnancy. She probably just isn't feeling them
until
earlier
she's
on.
later.
But as you get to that 3rd trimester, and especially as they're getting closer to labor, they're going to become more uncomfortable. They are not good at this. They are uncomfortable. They're just not technically real contractions, but definitely she's going to feel them much more in that 3rd trimester, and they're going to get more and more uncomfortable as she gets closer to going into like a real labor. Hagar's sign, right, so all these different things that need to change in the uterus. The lower segment of the uterus is going to soften, which is going to cause it to become very easily compressed, like you would push on the bottom of the uterus. You'd be able to compress it. The purpose of that is that at some point, we need a baby to work its way down to that lower uterus and fit through and come out. Right, so the lower uterus has to soften up because if it stayed really rigid, the baby's body would not be able to navigate. So Hagar's sign is the softening of the lower uterus. The myocardium itself is going to enlarge up to 15%. Pregnant women will often have a change in their heart sounds. That sounds like a murmur. That's considered a normal finding in a pregnant patient. and will usually go away about a month after she has the baby. There's going to be an increase in blood volume, increase in plasma volume, and red blood cells. All of this because we need more blood to be able to go to the placenta. We have a whole separate organ now that we've never had to give blood to, and now the baby requires so much of it, right? So everything is going to ramp up. Know this, in the third trimester, if we were to do blood work on mom, especially as she's getting close to delivery, we may notice an increase in white blood cells, which, you know, in a different patient, maybe we would be concerned. But in a patient who's about to deliver a baby soon, it's normal, the body does that. Increases white blood cells to protect the patient against pathogens that can lead to infection. So leukocytosis at the end of pregnancy is going to be considered normal. A physiologic anemia is also very common. It's not a real anemia, right? So some people actually are genuinely anemic during pregnancy, but all pregnant patients probably have some of this physiologic anemia. There's so much more plasma. There's also more red blood cells, but it tends to be more plasma. So if we were to check their blood, it's kind of diluting those red blood cells, so it makes the numbers seem like she's actually anemic. She's not, it's just that there's so much more plasma in there. So this is not a true anemia, we don't have to do anything about it. It's just a normal finding in the pregnant patient. Right, the biggest change is cardiac output, up to 50% more, an increase in cardiac output, which is crazy to me, right? That's a lot, that's a big difference. We want to be aware that mom is going to be at risk for supine hypotension. Right, if we see in that that picture, right, if mom is just lying supine and that baby is big enough, it's just kind of sitting right on where that heart is. So what it will look like, right, she has increased pressure on the vena cava and the aorta. The patient's going to say that she feels dizzy, right, she feels like she's going to pass out. We want to turn her. We need the blood to go back to where the heart is. So we want to position her, put a wedge or something under her right hip to tip everything back to the left. Right, so know what that would look like. She's supine. She's going to say she feels sick. She's going to pass out. We're repositioning her. That's on the HESI. We're repositioning her onto her left.
Does it have to be on the left or could be on the right?
We want her to be, so we're going to wedge the right hip up because we want everything to go back to the heart. So blood flow obviously is going to be different because it now has to go to different places, right? It has to go to this whole other organ, to the placenta, to the uterus. More blood is going to the uterus than has ever before. As the uterus gets bigger, it's going to obstruct the veins that go down in the lower body. So we're going to have pooling of blood in the legs. We're going to see like like little clots or varicose veins and things like that. It's also because it's cutting off anything in the lower body. This is why hemorrhoids develop, right? There's just less blood circulation going there. Definitely know that pregnancy is considered a hypercoagulable state. The blood has an increased ability to develop clots. So the purpose of that, the reason the body does that is it's trying to protect against hemorrhage when mom delivers. The problem is it's putting her at risk for every type of clot, right? Embolism, pulmonary embolism, deep vein thrombosis, any kind of clot is at increased risk now. Okay. Gravidity is the number of pregnancies, right? We learned that last week. You can probably see this better on your screen, but what that's going to include, right, number of pregnancies, is it's going to include the current pregnancy, right? So don't forget the current pregnancy. On the next slide is an example of what a question looks like, asking about GTPAL. But when you're calculating how many pregnancies the patient has, I feel like the common mistake is that you forget that it mentions that the patient is currently pregnant, right? So it's going to include the one that she's pregnant with now. It's going to include any miscarriages, abortions. It doesn't really matter what happened with the pregnancy. It's counting as a pregnancy. Twins and triplets are going to count as one pregnancy, right? It's not a different pregnancy. It's two babies, but it's still just the one pregnancy, so we're not counting them separate. The T in GTPAL stands for term pregnancies, term births, meaning the number of babies that are born at full term, which is 37 weeks to 42 weeks. So what we're including in that T, right? So G is every pregnancy. T is the number of born at term. So any pregnancy that was lasted, 37 weeks on. It's going to include whether that baby was born alive or stillborn. And again, twins and triplets are only counting as one. It was still one delivery, even though it resulted in two babies. The P in GTPAL is preterm births, right? So this is going to be any delivery that happens between 20 weeks and 36 weeks and 6 days.
20 weeks and
20 weeks to 36 weeks and 6 days. So right before that 37-week mark.
things.
Again, it's including any, it doesn't matter if the baby was born alive or it was a stillbirth. Twins and triplets are still counting as one. The A in GTPAL is for abortions or miscarriages, right? I said last week they mean the same thing. That's a delivery that happened before 20 weeks. Again, twins and triplets are counting as one. And then the L is currently living children. So that's any child that they have now who is living. If a child passed away, they're not included in this number. Twins and triplets are now going to count as separate people. The only place in the GTPAL where the twins and triplets are counting as individuals. Or spontaneous abortions, they mean the same thing. It's a loss of pregnancy before 20 weeks. The most common cause of like a spontaneous abortion would be some kind of congenital chromosomal anomaly that sort of happened that made it that the pregnancy can't continue. There's different types of miscarriages, right? So there's an incomplete abortion where some of the products, so when I say products of conception, I mean like the developing fetus, the lining of the uterus that built up for the pregnancy. Anything that sort of was starting to grow, if you're going to have a miscarriage, it has to come out, right? So an incomplete abortion is when it doesn't, everything that needs to come out doesn't come out. So some of it kind of still stays in the patient. So for that, we would do a D&C, right? We've spoken about D&C, the dilation and curettage, where they're going to go in, they're going to dilate the cervix. The patient will be under general anesthesia. They'll dilate the cervix and then go in with a suction tool and remove anything else that needs to come out. If this happens after 14 weeks, usually even a little earlier than that, they'll do a D&E instead, which is dilation and evacuation, where they're going to, same thing, general anesthesia, they're going to dilate the cervix, but they're going to go in with tools and kind of just pull out what needs to come out. The reason we can't do the D&C is because what's in there is too big to fit through the suction machine. A complete abortion means everything that had to come out came out, right? Everything was expelled on its own. And then a missed abortion, right, is where we're not going to see like, bleeding or anything like kind of obvious that there was a miscarriage. This is usually going to be the patient goes in for their regular visit and there's no heartbeat, right? So everything is still in there. It needs to be in there. What they may notice is that their symptoms of pregnancy start to disappear, right? So maybe the week before they were, nauseous in the morning and their breast tenderness, whatever the case may be, and now they're starting to notice those things kind of went away. It's because the HCG is dropping, because the pregnancy is over. So for that, we would do an ultrasound, obviously, to confirm. That's how usually it's going to be diagnosed. In that case, we would need to either do a D&C, or they can give them something like Cytotec PO to just kind of get, it's like the abortion pills, basically what it is. If a patient is having recurrent spontaneous abortions, right, they're having repeated miscarriages, one of the possible things that's causing this could be cervical incompetence or cervical insufficiency, right? So that means that the cervix is opening for no reason, right? So there's nothing actually wrong with the pregnancy, right? That's growing normally, but for some reason the cervix is just opening. There's no labor, it just opens, and then therefore they're going to lose the baby that way. So what we could try to do for that is a cerclage. A cerclage is where they're going to go in and literally stitch up the cervix. So they stitch the cervix closed, and you're hoping that what's going to happen is that you're going to get to full term and then cut the stitch. So that's one thing we could try to do for somebody who is, we're noticing is having this happen, more than once or twice. Another one of our hemorrhagic conditions is this gestational trophoblastic disease, or it's a hydatidiform mole or molar pregnancy, right? So what happens is, this is pretty rare, right? A mass or there's going to be a mass or growth in the uterus. Instead of a fetus developing, this mass grows instead, and this mass could lead to cancer, right? So this is a little scary, right? So our risk factors for that is someone who's had a previous molar pregnancy. So if you had this happen once, you're 10 to 15 times more likely to have it happen again. Maternal age, right? So it's considered extremes of maternal age, right? So under 15 or over 35. And then if they've had prior miscarriage before. Our manifestations of this is going to grow very rapidly, right? So not as slowly as a fetus would. It's kind of like this grape-like cyst. They're just going to keep kind of, producing more and more. So one thing we're going to notice is they're going to have an unusually large uterus for their gestational age, right? So remember, like week 2, when we were looking at that diagram of, okay, at 12 weeks, this is where the fundus should be. At 18 weeks, at 20 weeks, it should be at the belly button. With this pregnancy, the uterus is going to be ahead of the game, right? It's going to be like she's 8 weeks pregnant, but we feel something by the belly button, like it's growing rapidly, right? So that's one of our signs of this. It's going to be a fundal height that doesn't make sense. They could have bleeding, pelvic pain, and pressure. Their HCG levels are going to be very, very high, like not normal pregnancy high, like extremely high, and for that reason, they're going to have these sort of extreme symptoms of pregnancy. So they're going to have severe nausea and vomiting, not our regular morning sickness. We can see preeclampsia and high blood pressure in them before 24 weeks, right? So we know from becoming best friends with chapter 10 and already knowing everything that's in this chapter that generally we shouldn't see preeclampsia until like 28 weeks and on. So if we're noticing those symptoms like in early pregnancy, it could be because they kind of have this like rapid acceleration going on, right? So any high blood pressure, preeclampsia before 24 weeks, this could give them hyperthyroid, and there's not going to be a fetal heart because there is no fetus. There's not a baby, it's just the cyst that keeps growing. So for diagnosis, right, we could do a sonogram, right? We would see that there is no fetus there. The HCG level is going to be the thing that we're really going to want to monitor, right? The HCG will be very high. We also want to check that this, if it is sort of cancerous, we want to make sure we don't see any signs of anything anywhere else, right? So maybe check the lungs and things like that. Our treatment for this is the pregnancy. We need to end the pregnancy, right? So we're going to do a D&C and then follow like routine visits to make sure, the way you would if you basically had cancer. We're just going to keep assessing to make sure we don't see any signs of anything growing there. They're going to have to come in for HCG levels for 6 to 12 months because that's how long it could take for this to sort of either go away or not go away. if we see that HCG increasing, it's indicating that we left some behind. This is still happening, right? So we want the HCG levels to go down and stay there. If they start going back up, it's a sign that maybe that it's growing back. So we would want to watch them for 6 to 12 months. For that reason, they should not get pregnant during that time, right? So that could be terrible news for somebody who's wanting to start a family, to say for the next year, you can't. Instead, you're going to be coming for blood work and sonograms and all this stuff. So they have to avoid pregnancy during this time, and then just treating all of their other kind of conditions that came along with this, right? So if they have the hyperemesis, we're going to treat that. If they ended up with the hyperthyroid, treating that until everything kind of gets under control. Ectopic pregnancy. So an ectopic pregnancy is when that fertilized egg does not attach where we want it to attach, right? So it's going to implant somewhere not in the uterus, right? The pregnancy obviously should be in the uterus. If it implants somewhere else, it's an ectopic pregnancy. Usually it's going to be the fallopian tube. It's going to attach to the wall of the fallopian tube and not make it to the uterus. Our risk factors for this, right? What's going to put somebody at increased risk is any scarring. So if they've had previous uterine surgeries, right? Anything that would cause scarring in the fallopian tubes, where then maybe it would kind of get stuck on the way to the uterus. So scarring, infections, right? So certain like gynecological infections can also cause this to happen. And then, like I just said, previous surgeries, right? Clinical manifestations, pain. So usually pain is going to be a big one here. Once that pregnancy sort of gets big enough, they're going to feel it all, and that obviously there's no space for it to grow in the fallopian tube. They're going to start usually having, whatever side it's on, extreme pain in that area with some spotting. Our treatment really depends on if that fallopian tube is still intact or did it rupture, right? So if it ruptures, that's a bigger emergency, right, than if it's still intact. If the tube is intact, we can try to give them methotrexate, which will basically end the pregnancy, right? Stop the growth and dissolve what was already there, right? So we can try methotrexate. We can try a salpingostomy, where we're going to basically go in, just remove the pregnancy, and then put the tubes back together and let it heal. If it's ruptured, right, they come in, they're screaming in pain, they're bleeding everywhere, and it's because the fallopian tube ruptured, that's going to be a salpingectomy, where we're going to remove the tube altogether. Our main concern here is bleeding, right? So that's our biggest issue, is that we're afraid of hemorrhage, right? If it ruptures, this can kill somebody, right? So this is scary stuff. Risk for future infertility, right? Especially if they lose the fallopian tube. It's just, going to obviously decrease the chances of them being able to get pregnant in the future. Our next two, placenta previa and abruptio placentae, very important for you to know. Most of the questions are usually just trying to see if you know the difference between the two, right? It's a lot of questions of like symptoms, and then you have to know which one is which. So you'll see, we'll kind of compare them as we go. So placenta previa is when the placenta, right, where do we want it? We want it in the upper uterus, right, up and out of the way. That's where we want it. With this, the placenta is going to attach too low. It's going to be either very, very close to the cervix or right on top of the cervix, right? So not an ideal spot, right? We want it up and out of the way. We have our different types of previa, right? So that's on the next slide here, right? So normal placenta, up and out of the way. Marginal previa means it's just so close to the opening of the cervix there. Marginal previa is the only one that might resolve itself. The other ones, you have it. That's it. You have placenta previa. If you have a marginal previa, it's possible that as the uterus grows, it'll shift up just enough to not be an issue, right? So marginal previa may get better. Partial previa means that part of the placenta is covering part of the cervix, I guess. And then total is it's right on top, like completely covering the cervix. Our risk factors for this, probably our biggest risk factor is scarring, right? So scarring in the uterus. If you have a lot of scar tissue in there, right, let's say from D&Cs or whatever the case may be, any kind of scar tissue in the wall of the uterus, when that placenta tries to attach to scar tissue, it's kind of smooth, right? It may not be able to get a good kind of latch onto there, so it may kind of slide down to where there isn't scarring, right? So any previous surgery scarring in the uterus is going to greatly increase your risk of this. Over 35 years old, if they've had a previous previa, they're more likely to have another one. And then multiple gestations, especially when there's more than one placenta to be placed somewhere. Our manifestations, right? So again, I said you have to know the difference between this one and abruptio placentae, right? That's the symptoms. You really have to know which one goes with which, right? So for previa, painless, bright red bleeding. So painless previa, right? That's a common question on the final, on the HESI, on the NCLEX, right? Is painless. Any mention of painless bleeding, you should think previa, right? So painless, bright red bleeding, relaxed, non-tender uterus. So if you were to, we're not going to, but if we were to try to push on this woman's belly, it would feel like a normal uterus, right? It's not, there's no guarding or anything. They're going to have episodes of bleeding. So these are going to be our frequent flyers in triage, right? Our placenta previa patients, we're like, oh, we see that name again. They're back on the board, right? Because they're going to have all these episodes of bleeding because the placenta is in a terrible spot. And just, maybe they were extra active that day, right? And it sort of caused like a little shearing effect at the cervix. It's happening right at the cervix. So any bleeding that happens is coming right out, right? It's right there. So we're going to see them a lot in triage. And what we're hoping is that it's a small episode of bleeding and we can kind of just babysit them for a little while, watch the baby, and then send them on their way, right? What you don't want to happen with this patient is they come in and we can't stop it, because at that point, we just have to deliver the baby, whether the baby is viable or not, right? So episodes of bleeding, especially in the third trimester, we're going to really start seeing them come in. Visible bleeding, not concealed. So like I said, it's happening right at the cervix, right? So there's really nowhere for it to be concealed. It's where that bleed is happening, it's coming out. So we'll get a pretty good idea of the amount of blood loss they have. It's not staying concealed in the uterus because it's kind of happening right at the exit point, right? Intercourse can cause bleeding. This is a very important teaching point for us to, anytime a patient with previa even attempts it, guaranteed they're coming to triage with bleeding, and then they're all upset, right? They should not be attempting anything. There should be nothing going in the vagina at all because it can, interrupt sort of what's going on right at that cervix. But guaranteed patients will attempt it and will be in triage for sure bleeding. So that's an important teaching point for us. And then abnormal fetal position. The baby can't really be head down because the placenta is where the head should be. So they tend to be more likely to be breech, transverse, or just sort of like a little off where they should be. Our home management for this, right, so they're not currently bleeding, right, they just have this, is pelvic rest. So when I say pelvic rest, I mean no sex, right? That's the teaching. There should also be, right, so yes, that's one of our teachings, but for us to know as the healthcare providers, there should be no cervical exams, right? So most of our patients, if you've been to, L&D, triage, we're checking everybody. Everybody who comes in, whether they're there for anything, we just make sure that nobody's like dilating that we don't know about. So they'll check the cervix, right, with the fingers. Again, nothing should be going in there. So for a patient with previa, there's no internal exams that should be going on because of the risk of hemorrhage. Once they are bleeding, now they're inpatient, right? We're not going to send them home bleeding. So we are going to assess the bleeding. We're looking for signs of hypovolemic shock, right? Looking for signs that the bleeding has now gotten to a point that it's affecting mom. We're not going to do any kind of abdominal manipulation, right? We wouldn't do Leopold's maneuver to feel the position of the baby. We don't want to interrupt anything. There's already this placenta that's in a bad spot. That we want the baby on the monitor, right? So the EFM monitor and TOCO monitoring. We do not want this patient to contract, right? Because again, we don't want the uterus doing anything. Because where that placenta is, if she's contracting, she may dilate. And if that cervix starts opening, the placenta is attached to it, right? So we're going to create a bleed there if she starts dilating. So we do not want this patient in labor or contracting. So if she was contracting, we could give terbutaline, right, or breathine to stop the contractions. If this is it, right, this is the bleeding is too much, or she's full term and ready to deliver, it's going to be a C-section, right? The baby can't come, the placenta is blocking it. The baby can't come that way. So it's going to be a C-section if it's time. The one that goes hand in hand with this is this abruptio placentae or placental abruption. So again, a placenta problem, but in this case, it is in the right spot, but it starts detaching too early, right? So the placenta, we don't want to hear anything from the placenta until the baby is delivered, and now we want the placenta to separate and come out. So when this happens, it's separating before the baby's out. The baby's still in there, right? She may not even be in labor, it just starts separating. So there's total abruption or partial abruption. Total abruption, like meaning the whole placenta separates from the wall, is catastrophic. The baby's not going to survive, and hopefully she does, right? Because the bleeding is going to be, right, when we did the postpartum, right, when that placenta separates, the amount of bleeding that happens. So for this to happen while she's still pregnant this is a disaster, right? So total abruption is probably not going to result in a living baby. Unless you happen to be in the hospital about to go into the OR, you kind of would have to be right there. A partial abruption is a little bit different. You could, depending on how partial it is, you could have some time there. Our risk factors are all of our hypertensive things, our preeclampsia, eclampsia, hypertension. Previous abruption, they're more likely to have it happen again. Abdominal trauma, right? So patient is in a car accident, patient gets beat up, whatever the case is. Anything that could cause actual damage to the uterus, you run the risk of that placenta separating, right? So any patient comes in, they were just in a car accident, they look fine, we're getting them on the monitor, we're doing an ultrasound, and we're keeping them to make sure we don't see any signs of an internal bleed, because maybe it's just like a tiny abruption. So we'll usually keep them for hours to make sure we don't see anything. Another one that can cause this is cocaine use. Right? So cocaine use, I think I was telling you guys, if a patient does cocaine and you were looking at the contraction monitor, right, it's just all these tiny little contractions. They're not having big contractions and they go away. The uterus is basically doing this, right? The uterus is doing this. And when it's doing that, the placenta is going to start to separate, right? So most of our patients who have abruption, this is not the cause, but we do test every single one, right? Because sometimes a patient will surprise you. You don't think that's the reason, and then that's the reason. So any patient who has an abruption, we generally send a drug screen on them just to make sure that that's not what did it. Maternal smoking, premature rupture of membranes, all of those things can increase your risk. So the symptoms, we're going to see the difference between the two, because like I said, that's a big part of this, knowing the difference. This and the previa. So for this one, it's dark red bleeding. And then extended fundal height from concealed bleeding, right? So the other one did not have concealed bleeding. The other one, as the bleeding was happening, it was coming out. In this case, because just think of the location of where the placenta is, the bleed is happening all the way up here. It's trapped behind the baby, the cervix maybe is closed, so it's staying concealed because it really has nowhere to go, right? So with this one, we're going to see concealed bleeding, and for that reason, we're going to see the fundal height go up. Right, the top of the fundus is going to seem to be rising because the placenta the uterus is filling with blood, right? This patient is going to be in tremendous pain, right? So that's different. The other one was painless previa. This one, pain, right? That's sometimes going to be your first indicator. The patient comes in complaining of a few different things, a little bit of bleeding. When you go to so much as put the monitor on them, they almost kick you across the room because it's 10 out of 10 pain. They're like, don't touch it. It hurts so much to touch. It's because their uterus is so full of blood at that point that it's causing a tremendous amount of pain. So this one is very painful. So that's a big difference between the two. Concealed bleeding, we said. Hard abdomen, right? So this is different too. The other one still was, felt normal, right? Felt like a normal uterus. This one is going to feel, not that you really should be pressing, but it's like a board-like, rigid, whatever the term is, that's what it is, right? It feels like a rock because, again, it is full of blood. They are at risk for DIC, which we'll talk about in a second. And this is going to impact the baby, right? The baby is getting all the oxygen from the placenta. So if it starts separating, we may start seeing late D cells, bradycardia, whatever the case is, because now the baby is not getting the oxygen that it needs. So this is going to be immediate delivery, right there, because it's not going to reattach, right? The bleeding will just keep happening. So the second we identify that there is an abruption, we're going to the OR. So we're going to assess bleeding, no abdominal manipulation, obviously all of our hemorrhage measures. We're watching for DIC, which we'll talk about in a second. Emotional support. This is very scary. This is miserable, right? So for this to happen, especially if the baby doesn't survive, mom may end up really bleeding out and being, it could kill somebody, or she ends up, in the ICU for weeks. Like, this could really be a horrible situation. So definitely emotional support. But for the most part, it's just immediate delivery. Sometimes it doesn't matter, right? So if this is happening and the baby is not viable, it really doesn't matter, right? So like I've said before, this is not Grey's Anatomy. We're not picking who we're trying to save, right? It's mom, right? So with any of these, once she starts bleeding too much, it's over. We can't continue, right? So immediate delivery, sometimes not on my test, but you'll read something that'll say like, the patient is just about to deliver, she's pushing, and now it's an abruption. It's not impossible for this patient to have a vaginal delivery if she happens to already sort of be right there. Whereas with the previa, we have to. But for the most part, this is an emergency C-section because this is usually happening remote from delivery, right? You would only really be able to do a vaginal delivery if the baby was like crowning at that point. So what we're concerned about with trauma, right? So a patient gets into a car accident. We learned that domestic violence is highest when a patient is pregnant, comes in, just got beat up, right? Suicide, anything that causes trauma to mom, obviously is going to could be a hemorrhagic condition. We do have a blood test that we can do called the Kleihauer-Betke test that can identify to us that there's an issue with the placenta, that it's bleeding somewhere, right? So it kind of, we can see kind of fetal blood mixed with mom's blood, which we shouldn't really see, right? So we would do that. This is blood work. We would draw a patient comes in, they were just in a car accident. Like I said, we're not going to just send them home. We want to make sure there's no internal bleeding that we don't know about or like an issue with the placenta that we don't know about. So that's the blood test that we would do. Placental abruption, like we said, would be our number one concern here. And then again, management of the fetus is going to depend on mom's condition, right? If mom needs the baby to come out, the baby comes out no matter what. Hyperemesis gravidarum, that's persistent uncontrolled vomiting. So this is not our normal morning sickness. This is like crazy, right? This is a person who's like persistently vomiting, usually starts early in the pregnancy and will usually end with the first trimester, but some people have this the whole time, which is just absolutely miserable, right? So this is not, like I said, normal nausea vomiting. This is going to be vomiting that is leading to nutritional, insufficiencies, weight loss, like all the things we do not want for a patient who's growing a baby, right? So dehydration, right? So this is really an extreme case. We would watch this patient's weight, right? Because they're going to lose a ton of weight. Their I&Os, they're worried about dehydration. Dehydration can cause the patient to start contracting, can cause preterm labor, right? So we're concerned about her hydration. Similar to what we would do for other patients with the nausea vomiting, right? So, small meals, avoiding offending foods, right? If they have like real just aversions to, let's say, chicken, we're not going to offer them chicken. But this patient could end up hospitalized on IV TPN, like the full, until the pregnancy is over. And that's really going to be the only thing that sort of ends up curing it, is just ending the pregnancy. So we obviously are going to correct any issues that come up. We can give them things like Zofran, Reglan, to sort of help with that, the vomiting. But it's miserable. So with preeclampsia, right, develops after 20 weeks. Usually we're not going to see this until the 28 week and on. Definitely more common in the third trimester. Clinical manifestations, right, the obvious one is going to be high blood pressure, right? So a high blood pressure, protein in the urine. The way we test the urine is a 24-hour urine. So we give them literally what looks like a giant jug for them to they'll either do it in the hospital or they go home with it. And every time they go, they have to go in the jug, and then we get a number, right? So what we we're not, what would happen with this patient would be a 3+ protein in that urine, the 24-hour urine. Thrombocytopenia, renal insufficiency, it's going to impair their liver function, so we'll see sort of those labs, kind of elevate as well. Hyperreflexia. When you're looking at questions, right, on the final, on the HESI, make sure you're not confusing this, right, preeclampsia, with the magnesium. We're going to get to that in a second, like the magnesium symptoms, right? That's different, like too much magnesium. I feel like people kind of confuse them. So with preeclampsia, we're seeing hyperreflexia. Visual changes. They may gain weight, an excessive amount of weight in a short time. Obviously, most pregnant patients are gaining weight. This is going to be, they were just here last week and they gained 11 pounds in 6 days, right? Like something crazy. It's going to be an obvious, like that doesn't make sense. It's because they're retaining all this fluid. Our concern here is cerebral edema, right? Because that's what's going to lead to the seizure, right? So that's one of our things that can happen. But our main signs and symptoms are going to be our continuous headache, right? They're going to complain of a headache that doesn't respond to anything, right? They took their Tylenol, they took whatever they could take. They did all their usual headache stuff. It doesn't work. So a headache that sort of doesn't respond to anything and seems to not go away. Epigastric pain, right? So this can confuse people because they can think it's, like GERD or heartburn. Oh, I have heartburn, I'm pregnant, right? But it could actually be related to this. Visual disturbance, right? So sometimes they'll come in and they'll say, I'm seeing spots, I'm seeing blurry all of a sudden, right? Any visual disturbance. Swelling is also a symptom. It's not one of our 3 main hallmark symptoms because every pregnant patient probably has some degree of swelling. But with preeclampsia, we would see the swelling more like periorbital, like face. Hands and feet are kind of normal for pregnancy, but this is going to be more like a central edema as well. But those first 3 are the ones that are sort of like the hallmark signs for preeclampsia. Who's going to be at risk, right? So a patient who's never been pregnant before is going to be high risk. Obesity, family history of preeclampsia. So sometimes we'll ask, did your mom, your sister, did anyone else in your family have this? Being older than 35. And then our high risk is if they themselves had preeclampsia before, you're way more likely to then have it with the next pregnancy. If there's more than one baby in there. Diabetes is going to increase, autoimmune kidney disease, and if they already have chronic high blood pressure, they're more likely to develop this. There is also an interesting connection that they found where the dads play a role as well, because what they found was that if they had preeclampsia with one pregnancy, but let's say the next pregnancy was a different dad, the chances were almost back to like normal of like what a regular person's, right? So there is some sort of thing. So even like us in labor and delivery, we'd be like, oh, she was on magnesium last pregnancy, whatever. And then they say, but it's a new dad. We're like, terrific. Like we almost don't even care. Yeah, good. You know what? It probably is. Yeah, I don't know. I don't know how far. I don't know what. But they find that for some reason, if it's like a different altogether like combination of genetics there, that it greatly, it's almost like not the same risk factor. Yeah. So preeclampsia, that's just sort of our umbrella term. You could have, I don't want to say mild preeclampsia, but that's what we would say in real life. Like it's mild preeclampsia. But preeclampsia, right? So that's our severe preeclampsia. And what we're doing for regular preeclampsia is just, the only cure really is delivery, right? So that's really, we can't cure this. We can just try to control it during the pregnancy, right? Vaginal delivery is preferred, right? So know that vaginal delivery is preferred. Sometimes you guys hear like, oh, she's got high blood pressure. Like the best thing to do would be just emergency C-section. Let's get the baby out. That's actually more stressful on the body and could actually lead to more complications, right? They are at increased risk for bleeding. So we don't want to do a C-section unless we absolutely have to. So vaginal delivery is preferred if we could do it. We may induce them to get it moving, but vaginal delivery is preferred. This is what I was thinking, right? So we're watching the fetal monitor because of vasoconstriction to the placenta, right? So they could have less oxygen. It can impact their growth, intrauterine growth restriction. We may notice the baby now is not growing on the pattern. You know, baby is 37 weeks, but is measuring, 33 weeks, right? It can kind of fall off that growth chart. For home management for this patient, right, so meaning that they are not in severe preeclampsia and we're just trying to manage them at home, right, we can say decrease activity, but we're not doing bed rest for this patient anymore. They're checking their blood pressures regularly throughout the day. They're taking daily weights because, again, we're looking for that potentially big weight gain, which would be a sign of worsening condition. They're going to be followed up way more. And we want to tell the patient what the worsening signs are, right? If they have a headache that's not going away, if they start seeing spots, they gained 8 pounds since yesterday, something crazy, they should come back. They should come to the hospital or to the doctor to get checked out. But severe preeclampsia, you have preeclampsia, but now you're falling into this worst category that you don't want to be in, right? So the criteria to be considered severe preeclamptic, the blood pressure obviously is going to be much higher, right? Over 160, and then diastolic over 110. Again, there has to be protein in the urine. We're going to look for signs of HELLP, which we'll talk about in a second. This is an inpatient, right? So the other one we could have potentially, went home and managed at home, checking blood pressures. But for this patient, they are living with us. We're keeping them, right? They can't go home. They're going to be on bed rest. They're going to be on fetal monitoring. We're concerned with a preeclampsia that there's less oxygen flow to the placenta, so we're worried about the baby in that sense that may not be getting enough oxygen. We're going to use our medications, our antihypertensive medications, which is labetalol and hydralazine. Those are our two meds of choice. We want the patients to know once they go home, they have the baby, they go home, that they need to still be monitoring for this because this can still turn up for weeks after the pregnancy, right? So we have patients come back, 3 weeks postpartum, they're coming in with these high blood pressures and they're now on magnesium postpartum. So they should continue to monitor their blood pressures at home. And then obviously under the supervision of a doctor, they'll usually stay on their medication. So it's not usually like, okay, you're done. We usually watch them. Now they're keepers. They're staying in the hospital, right? Either in our antepartum unit or we're inducing them and it's time for the baby to come out. So our medications, labetalol, hydralazine, and then we're going to tell them to continue after. But our big medication for this is magnesium sulfate. That's the big one. Know your reason why we're giving this, right? We're giving this because we were trying to prevent seizure, right? I mentioned this to you guys week 1. Now it's finally here, right? With magnesium sulfate, we're not giving it to lower the blood pressure. That's the easy one to want to pick when you're taking the test because, yeah, it's preeclampsia, it's high blood pressure. This must lower the blood pressure. And it does. That's what's even more frustrating is that it probably will lower the blood pressure because it's a smooth muscle relaxer. But we have our hydralazine and labetalol to do a much better job at doing that part of it. We're giving this as an anticonvulsant because that's what it is, right? So we're giving this as an anticonvulsant to prevent eclampsia, right? So that's the only reason we're really giving this, right? The patient has severe preeclampsia. We're just trying to not get to eclampsia, magnesium sulfate, right? So we're giving this to prevent seizure. We're going to give this IV piggyback with a loading dose first, 4 to 6 grams over 15 to 20 minutes, right? So when you give this initially, right, that first dose, horrible, right? So we want to warn the patient that very suddenly they may feel very sick all of a sudden, right? Because it is a very big dose that we give them initially. Once it calms down after that 20 minutes and we kind of go to 1 to 2 grams, it tends to be more manageable. They may not feel great, but that first dose is going to could potentially hit you like a bus. So we're going to start it at a high rate and then lower to 1 to 2 grams an hour. Really have to know everything there is to know about magnesium, right? What our levels are. We really are looking for a range of 5 to 8. Know your signs of mag toxicity. So this is what I'm saying. Don't confuse this with your signs of preeclampsia or severe preeclampsia. This is different, right? So this means we've gone too far in the other direction. We've given them too much. magnesium, and now they have mag toxicity. So that what that's going to look like, sweating, they're going to look flushed, CNS depression, respiratory depression is a big one, right? All of a sudden their respirations are 10. Hypotension, right? Again, we've now swung too far in the other direction. Now their blood pressure is too low. Hyporeflexia, right? So that's different than the hyperreflexia of preeclampsia. Hyporeflexia. So we do regularly check their reflexes, right? And a patient who has MAG toxicity will not respond or have very weak responses to that stimuli. And then we're watching the urine output, right? So every hour we're recording everything. So we want over 30 mLs, right? So under 30 mLs, we're worried about toxicity or just really a worsening condition at that point. So what we need to have before we start magnesium sulfate on any patient is calcium gluconate. We need to make sure we have that on the floor. We used to actually tape it to the IV pole with the magnesium, but they're like, you got to lock that up. No, we're only giving this if they have MAG toxicity, right? So if we figure out like, yes, their MAG level is, 10, and they're having all these signs, we would give them calcium gluconate. But we can't start it unless we know we have that on the floor, because once you know you have it, you shouldn't be trying to like scramble to get it from the pharmacy. So our nursing management, right, for this patient who's on magnesium, right, is obviously we're monitoring their blood pressure, their respiratory rate is big, right, because that respiratory depression that could happen, deep tendon reflexes, urine output. This is like almost like a one-to-one, bless you, a one-to-one patient because you're constantly sort of monitoring all these things and documenting everything. We're going to do serum magnesium levels every 4 to 6 hours, right, so very regular blood work for them. Seizure precautions, because if they're on this, they have severe preeclampsia. So any patient with severe preeclampsia, we should have seizure precautions. We're going to have the calcium gluconate ready to go. Diuresis would be a positive sign that things are working, right? So it would be a sign that if their urine output is increasing, that this is going well. A lot of times if the patient is on magnesium sulfate, during labor, they then continue it for another 12 to 24 hours in the postpartum. So they deliver and then we put them in the recovery room for a day and they'll be on magnesium continued just to make sure that it's sort of really controlled. Were you going to ask a question?
The 5-8 is the given dose or what their levels are?
No, if we drew their blood, that's the range we want. Yes. We want it to be, so the therapeutic range is 5 to 8. If it's lower than that, that means we're not giving them enough. If it's higher than that, we're at risk for toxicity here. So 5 to 8 is the magic number that you want to be in when you check their blood. Yeah. If that didn't work, right, we're going to graduate to eclampsia, right? So that means the patient is now seizing. So it's an extension of severe preeclampsia. Now it's going to go to seizures. Once you have one seizure, you now have eclampsia. Seizures, some of the reasons we don't want a patient to have a seizure, a pregnant patient, is it's going to stimulate uterine irritability, right? So this can put the patient into almost immediate labor. It could rupture membranes and can cause placental abruption. If mom is seizing, the baby is not doing well, right? So the baby, usually if mom is seizing and we happen to have a monitor on her, we're going to see bradycardia. We're going to see decreased variability. We're going to see late decels. If they kind of stay in that seizure, it's possible then we see nothing. Right? So the baby could die during the seizure because of just the decrease in heart. We'll see the decrease in heart rate. We're only delivering though when the patient is stable. Right? So again, mom is our priority. If mom is seizing and we know, like unfortunately I've had that patient, right? Mom is seizing and we see the heart rate on the baby is going and it's getting lower and it's getting lower and it's getting lower. We're just taking care of mom, right? And we'll have to explain that after mom is, stable, but we're not running to the OR to try to get the baby out, right? Mom has to be stable, right? So that can happen. So we're only delivering once the patient is stable. And generally, if she's had the seizure, once she's stable, we are going to then do emergency C-section at that point. So because now she's in eclampsia, but we're not
basing that decision based on if the baby is doing well or not.
Should have a seizure during.
I mean, she could. Yeah. Eclampsia is yes. Eclampsia is preeclampsia that's now graduated to a seizure. Once you have a seizure, you have eclampsia. So one thing that is sort of related to preeclampsia is HELLP syndrome, right? So HELLP syndrome is hemolysis, elevated liver enzyme, low platelets, right? That's what the HELLP stands for. So it's a serious complication related to preeclampsia, usually severe preeclampsia. They're going to complain of right upper quadrant pain due to liver distension, right? So this is impacting, right, those liver enzymes. Headache, nausea, vomiting, severe swelling. Right, those are what our labs would look like, right, as far as all of those things, that is mentioned in the name of it. Our management for this is going to be pretty much what we would do for severe preeclampsia. Our magnesium again, labetalol, hydralazine for the blood pressure, fluid replacement, strict ionos. And then our chronic hypertension, right, that's somebody who either already had it before, or it happened before 20 weeks, or it continues 12 weeks postpartum, right? Just know that they are at great risk for preeclampsia, 25% chance of them developing preeclampsia during the pregnancy. There's a link to diabetes and obesity, right? So generally, this is going to be managed with diet, right? Low sodium, high protein, just like our usual blood pressure stuff. RH incompatibility, so we spoke a little bit about this with RhoGAM, right? What RhoGAM does for us. So mom is RH negative and the baby is RH positive. So when the blood from the RH positive baby enters the bloodstream of the negative mom, antibodies will develop to attack that invading antigen, right? So we could do our indirect Coombs test during the pregnancy, right? The Coombs test is after the pregnancy. We do that to the baby. Indirect Coombs test will determine if those antibodies are present in the mom's blood, right? So this is a blood test for mom. Luckily, we have our RhoGAM, right? So that's our IM injection. That's going to prevent those antibodies from developing. If the patient has had like a normal pregnancy, has not had an amniocentesis or CVS or any sort of anything that could have caused bleeding, we're giving that to the patient at 28 weeks, and then we give it again postpartum. What happens is once the mom has those antibodies in her blood, it would attack the next pregnancy, right? So you're almost doing it to protect the next one. So we're giving that at 28 weeks in postpartum.
When you administer postpartum, it's for the second baby?
So really, both will protect the next pregnancy. Well, at that point, once the baby is delivered, we will send the baby's blood for blood type to see if maybe the baby was negative too. We don't know. And sometimes we have that where the patient will say, well, I don't need it because my husband is RH negative, I'm RH negative. We're still like on paper, like we're going to say you need to have it because we don't know your situation. We don't know if that man is the dad, right? So we have had patients, they can refuse it if they want, but that's like documentation that they need to sign because we don't know, we weren't there, right? So we don't know. But generally, if it was two RH negative people, wouldn't, the baby's going to have, yeah. So 28 weeks postpartum, but we're also going to give it for these other special reasons, which would be if mom has a miscarriage or an elective abortion, doesn't really matter. We're going to give it, again, that would be protecting the next pregnancy. Any kind of abdominal trauma. They were in a car accident. We're giving them RhoGAM just in case there's a little bleed somewhere. Amniocentesis and the chorionic villus sampling, again, because it's a puncture and blood may mix, they're going to get RhoGAM. Other big one is diabetes, right? There's all of our different types. For the most part, we are looking mostly at the gestational diabetes, right? Because that's diabetes that's going to be onset during the pregnancy, right? Our signs are our usual, the 3 Ps of diabetes, right? Polydipsia, polyuria, polyphagia. With diabetes, right, so just generalized diabetes, early pregnancy is going to look a little bit different than late pregnancy as far as insulin needs and things like that, right? So in early pregnancy, there really is little change in what mom needs at that point. The patient is actually going to be at increased risk for hypoglycemia at this point. Whereas in later pregnancy, now the baby is growing, and the placental hormones are going to shoot up. The hormones can create a resistance to insulin, and now that's where we're going to see, the insulin needs increase, right? So generally, early pregnancy, we're more worried about hypo, and then we're going to start seeing in the second, third trimester, we're going to see that shift. During birth, right, while mom is delivering, right, while she's in labor, we're watching maternal glucose levels regularly, right, and correcting. The more controlled mom is, the more likely it is that the baby will be more controlled when the baby comes out, right? So, right, our big concern with diabetes with the baby is hypoglycemia, right? We're less likely to have that if mom's levels have been really well taken care of throughout the pregnancy and has kind of maintained, a stable blood glucose. So we're going to continue that during, labor and the delivery. Once she's postpartum, right? So gestational diabetes, once you're not pregnant anymore, it's gone, right? So it's different than preeclampsia where we still have to kind of watch them for a period of time. Generally, like as soon as that baby is born, you are not diabetic anymore, right? So the need for insulin is going to fall. Breastfeeding is encouraged. Usually, if you were on insulin during pregnancy, you don't need it anymore. Like we'll check while she's in the hospital, but for the most part, it's done. Like you're done with that. Half of women who have gestational diabetes are going to go on to develop type 2 later on. We would encourage breastfeeding for a diabetic patient. We've spoken about that. Our maternal effects of diabetes, right? So again, first trimester hypoglycemia. They are at risk for certain like fetal malformations in the development of the baby, spontaneous miscarriage. They're more likely to develop preeclampsia, ketoacidosis, and polyhydramnios because, right, so polyuria is one of the things that comes along with diabetes. The baby will have that too. So excessive fetal diuresis is going to lead to more amniotic fluid. So that's why they're more likely to have polyhydramnios. A big thing associated with this is macrosomia, the big baby, right? Especially if the diabetes is not well controlled, right? You could have 13, 14-pound babies, right? If they really didn't control this, right? So shoulder dystocia, big increased risk for birth injury, shoulder dystocia, C-section, postpartum hemorrhage, all the things that come along with a giant baby. Our fetal effects, right? So it can lead to like certain malformations in the development of the baby that are going to lead to, defects, birth defects, small for gestational age, IUGR, and then macrosomia. Newborn effects, right? So once the baby's born, hypoglycemia is going to be the big one, really, right? It will also increase their risk of respiratory distress and jaundice. The reason I just put in the notes down there, the reason for that hypoglycemia in the newborn is that they were had insulin production to meet their mom's needs. And now they come out and they don't actually need all of this because now they are not attached to mom anymore. So that's going to drop their blood glucose. Our management, right, is possible for someone to be diet controlled, right? So usually if a patient comes in and they say, oh, I have gestational diabetes, we want to know how it's being managed because it could just be diet controlled. So diet high fiber, complex carbs, lean protein, whole fruits and vegetables. They're going to be doing self-monitoring at home, right? They should be checking their glucose regularly. And then they could be on insulin as well. It really depends on the situation. Again, the insulin needs first trimester are going to decline. Second and third very quickly are going to increase. Postpartum rapidly decline again. And they'll need less insulin postpartum if they are breastfeeding. So some of our risk factors, obesity, if they had gestational diabetes in a previous pregnancy, they're more likely to have another one, multiple gestations, advanced maternal age. certain high-risk ethnic groups. If they have PCOS, polycystic ovary syndrome, that can also increase their risk as well. Know about your screening, right? The two different tests that we do. The first test that everybody's going to get is the glucose challenge test, or the GCT. Generally going to give that around 24 weeks, right? So they'll go to the lab to get this done. It's not a fasting test, right? So they do not have to fast for this. They're just going there and they're going to drink this oral glucose solution. And then they're going to test her blood in an hour after she drinks it. So once she finishes it, they wait an hour and they test the blood. Abnormal would be over 140. If it's abnormal, they now need the 3-hour test. So from the first test that we're doing, we're not diagnosing anything, right? If it's abnormal, she now has to go back for the 3-hour test. So that's the 3-hour glucose tolerance test, the GTT. This is a fasting test, so she has to come to the lab fasting. We're going to take her blood fasting, then she drinks the drink, and then we test her blood at 1 hour after the drink, 2 hours after the drink, and 3 hours after the drink. And you live there. You live in Quest. And they won't let you leave. Like, they really watch you. You, like, cannot leave the lab until they've taken all of the blood from you. So you are tracked in the Quest diagnostic lab. So once you now, let's say you fail that one, now you are gestational diabetic, but that's the one that's going to diagnose you with it. So diet, right, possible to manage with only diet. Exercise is encouraged. Blood glucose monitoring. We also have meds, right, so they could be on something like a glyburide or metformin. Insulin is really preferred, though. If you need a med, they usually just put you on insulin, but you could be on a PO medication. Fetal surveillance, you're going to be going to the doctor a lot more for this baby to be watched, especially in their growth, and kick counts, because we're concerned about less oxygen getting to the baby through the placenta. So we want her to really be taking notice if those kicks are, decreasing. Deficiency anemia, right? So for that, we have our prenatal vitamins, right, have iron in them. They could take iron supplements. We're concerned about pica, right? We've spoken about that, right? They're eating the wall, chalk. Yeah, they're eating the little ladies are eating the wall. Chalk, dirt, ice, anything that's non-nutritive, right? Something that would have no calories to it. If they kind of are consuming that in large quantities and replacing meals with that, that's pica. Our folic acid deficiency anemia, right? So we spoke about that with our nutrition, right? Folic acid is very important. The need for it doubles in pregnancy. And if they're low in this, it can cause neural tube defects, right? So that's the big thing that it really reduces the risk of, is the neural tube defects and miscarriage, right? So for this, we have our prenatal vitamins that have the folic acid in them. And then our food sources. HESI hint, know all of your food sources, because maybe the patient doesn't like green leafy vegetables. Because of course the HESI would. Of course they would, right? So know all of them, because that could show up for you. Know your non-green leafy vegetables that are on this list. Infections during pregnancy, right? So rubella, obviously prevention is key. Ideally, our patients would be vaccinated before they got pregnant. But if they do develop rubella during the pregnancy, they're at risk for miscarriage, stillbirth, severe birth defects, deafness, heart defects, cataracts for the baby. Once we give the vaccine, they shouldn't get pregnant for about 28 days after. Herpes simplex virus 2, right? So genital herpes. Acyclovir throughout the pregnancy is really the most recommended, because it's going to hopefully prevent an outbreak from happening around the time of delivery, right? So if a patient comes in who has herpes simplex virus 2, genital herpes, we do a sterile speculum exam, right, where they're going to go in with a speculum and really take a look at everything, like with a light and everything, just to make sure we don't see any active lesions, right? There's no active outbreak going on. If there are no active lesions, they can have a vaginal delivery. If there are active lesions, they have a C-section, right? So it's not impossible for a patient with this. Most of them do have vaginal deliveries, as long as they've been on their medication and they don't have an outbreak right at that time. If they did have active lesions, let's say they come in, sometimes they don't tell us they have it, they have no prenatal care. It's life-threatening to the baby if the baby ends up acquiring this on the way out. HIV, right? So this is one of the things that breastfeeding is contraindicated. The most important thing here would be this antiretroviral therapy. We want mom to be on this preferably before the pregnancy, during labor, after delivery, right? We want her on those antiretrovirals to hopefully get her, the amount of it to be almost non-existent in their blood. So our retrovir in labor, right? So mom will have that hanging throughout labor, and then we're going to treat the baby. When the baby comes out, the baby will also get those medications, which we want to usually start that within 6 hours of birth to have the baby on those same medications. The baby may test positive for up to 18 months after birth, or we're still going to test them, but we should still, if it comes back positive, we should still test them up to 18 months because some of mom's antibodies may still be circulating and may be triggering a positive, right? So it may take a full 18 months to really, they may test positive in the beginning and they're not actually. But the most important thing is if mom is well controlled, taking her medications, then hopefully then it won't go to the baby. Toxoplasmosis, this is the one that with the cats. We spoke about this in nutrition. So just our education here is to avoid changing the cat litter when you are pregnant. And then cleaning your fruits and vegetables, cooking meat to a certain temperature, good stuff like that. And then finally our GBS, our group beta strep, right? If you've looked at any charts at clinical, right, we always know everybody's GBS status, right? Are they GBS positive, GBS negative? So this is a strep that's found in the vagina, urethra, and rectum. Usually asymptomatic, right? So usually the patients have no idea that they have this. It's super common, 20 to 25% of pregnant patients are GBS positive. So just in regular life, it really does not, it's not impacting anything. The only time we care is during pregnancy because the baby can end up with it on the way out for vaginal delivery. So we test everybody for this, right? Because it's so common, 20 to 25%. Between 35 and 37 weeks, we'll do a swab at whatever their prenatal visit is during that time. They'll do a swab and test for this strep if they have it, right? So they're GBS positive. They're going to get a penicillin in labor, right? Usually every 4 hours, depends on the medication, but if they're getting a penicillin every 4 hours during labor, our goal is for mom to get 2 doses of that antibiotic, right? Once they have 2 doses in, it's usually good for the baby. If they only get the 1 in, it's a little bit more risky. So generally, ideally we want her to get 2 doses before the delivery. We're giving this preventatively, right? So it's just, we're trying to prevent GBS infection in the newborn. So this patient will have a vaginal delivery, can have a vaginal delivery, but this is what we're going to do to try to prevent that transfer of the strep to the baby. Can lead to serious illness, meningitis, pneumonia, and death for the baby if the baby gets it. Yeah, so we really have to treat them. If the patient is a C-section, we don't care. Then they could be GBS positive all they want because the baby's not going that way, so it really doesn't matter. So we're only treating this if we're trying to have a vaginal delivery. And we're going to give clindamycin if allergic to penicillin. 11 is the childbearing family with special needs. Right, so our adolescent pregnancies, some of our implications for maternal health in atolescent pregnancy, they're at much increased risk for all of our hypertensive conditions, so preeclampsia, eclampsia, preterm labor and birth, depression, substance abuse, domestic violence, poor nutrition, self-care, and stress. They may delay seeking prenatal care, right, especially if their parents or whoever doesn't know that they're pregnant. They may kind of put off getting any kind of care. And if we're talking about a really young child, they may not realize that they are pregnant. That's the sad part of what we do in labor and delivery sometimes. Once somebody has 1 teen pregnancy, they are at an increased risk to have a second. This is going to impact mom's developmental milestones, right? Because she's technically still a child herself, right? And there's those milestones that the adolescents have to go through that we spoke about in peds. This is going to obviously impact that, right? Because she's now going to be put in this, this big role, right? There can be issues with bonding and embracing the parenting role because usually this is not an intended pregnancy. Because they haven't met, especially if we're talking about the younger adolescents, if they haven't met those certain developmental milestones themselves, and then we're now kind of asking them to take care of a baby, right? It can impact their patience that they have. It can impact their, sort of their ability to parent. Obviously, resources can help getting them involved, keeping them socialized, right? So that's big with the teenagers. That socialization is so important for their development, and now they find themselves in a position where, none of their friends have a baby, right? So it's very easy for them to feel very isolated. So trying to find them, support groups, just anyone that they can talk to. Our assessment, right? Generally going to be looking at them, the way we would anyone, but we do want to just be more aware of their blood pressure because of that risk of preeclampsia and all of our hypertensive conditions. They're more likely to have iron deficiency anemia and checking them for STDs. We want to look for any risk factors in their lifestyle that we may have to address. Nutrition, smoking, alcohol, drug use, unprotected sex. Screening for physical and sexual abuse, right? What was, how did this pregnancy come to be, right? There may be a really sad story here. So just kind of getting to the bottom of that. How old is the person who, the man, right? So trying to find that out because we may have, a bigger issue here that we need to take care of. And then kind of evaluating mom for where she's at in her developmental task, how we can kind of help, kind of get that parenting going. Assessing the knowledge of infant needs, and then also assessing like what's her support, right? What's the support system? Does she have family who plans on helping her? Is the father of the baby involved, right? So we just want to look at all of those different things. Our interventions, we want to eliminate barriers to healthcare, right? So we want to help locate a clinic, a doctor's office that they can get to, right? Because they may have limited transportation. So we want to make sure that they have access to a place that they can actually get to. We want to make sure that we're not having a negative attitude towards them, right? Because then why are they going to want to come see us, right? If they feel like they're being judged or they're being spoken to like they are a child, it's going to kind of cause them to maybe not show up for the next appointment, right? So making sure that we're not having a negative attitude. Just a lot of teaching. We don't want to seem like we're like an authority figure, right? We want them to feel like they're on our same level. If they're 15 years old or younger, we want to use more concrete explanations because they don't really have that abstract thinking yet. So we need to really just be mindful of how are we explaining this? Are we explaining this how we would explain it to a 30-year-old? You know what I mean? We have to like think about our language and really making sure that they understand what we're saying. Again, helping with the isolation, referrals, and all that. Alcohol is the worst, right? So alcohol is going to do the most damage than any other substance. It's going to cause birth defects, mental delays. Of all substances, alcohol causes the most significant harm and long-term impact. The baby cannot metabolize the alcohol. So our neonatal effects that we're concerned about, right? The alcohol reaches the liver, which is unable to metabolize it. So fetal alcohol syndrome is our concern. So what we're going to look at with fetal alcohol syndrome, they're going to have prenatal and postnatal growth restriction, right? So as a fetus, they're not going to grow appropriately, and then probably after, like in newborn and a little bit older, they're likely to have some kind of like impact on their growth. CNS impairment, and then they're going to have definitive facial features that we associate with fetal alcohol syndrome. Right, so those are the facial features. We'll get to that. Right, so growth restriction in their weight, height, and head circumference. CNS deficits, intellectual incapacities, learning disabilities, ADD, issues with their short-term memory, and then they have these specific features, right? So microcephaly, their head is going to be smaller. They're going to have like these openings. You can kind of see where, like in between the eyes, right? There's like this line right by the side of the eyes. They're going to have very flat mid-face. They won't have like a groove above their lip and then like a thinner upper lip. So they sort of have like these definitive features that we would suspect alcohol that mom was taking alcohol. We can go to opiates, right? So our morphine, methadone, OxyContin, our usual heroin is in here, right? Heroin is the most frequently used abused drug in pregnancy. Well, hard drug, not. CNS, it's a CNS depressant, and it rapidly crosses the placenta, so the baby does get the full effect of the opiate. As far as mom goes, it's going to impact, I mean, if you're addicted to heroin, you're probably, nutrition may be impacted, maybe just having sort of like a risky lifestyle can lead to potentially STDs, HIV, maternal death, placental abruption. For the baby, right, it could lead to growth restriction, fetal death, preterm labor. The biggest problem here with heroin is that there's periods of like overdose where you're kind of, taking a lot of heroin, and then there's a very quick drop off where it's withdrawal, and that unsteadiness of it is what's going to cause hypoxia in the baby. So a patient who is, let's say, on methadone because they have an opiate addiction, tend to do pretty well because it's a stable amount that they're getting. So there aren't the high highs and low lows, right? So it's more controlled when they're on like a methadone for that addiction. Our concerns are going to be neonatal abstinence syndrome, seizures, birth defects, neonatal absence syndrome, right? Signs of that would be high-pitched cry, right? So we spoke about this about the newborn. We don't want to hear a high-pitched cry. It's a sign of something potentially CNS that's not right. They're very irritable, right? They kind of have like that twitchy movements, right? We want to really kind of wrap them tight. They need like that feeling of being, kind of locked in. They're going to be poor feeders, sweating. They're very uncomfortable, right? They're going through withdrawal, right? So we want to look for these signs because a lot of times these patients are not going to tell us what they've been using. The infant with congenital anomalies, right? So let's say baby, a lot of these things are going to be diagnosed before now. We have such great prenatal screening. So you're usually not going to be surprised by something, but sometimes, sometimes you are going to be, the baby's going to come out and there's going to be something that was not caught. We want to make sure that we're letting the patient know of the anomaly once it's found, right? We're not trying to like hide the baby's face. We want to inform them right away. If they did the prenatal testing and something was caught, it kind of gives them time to come to terms with it, right? So almost like a little anticipatory grieving of, kind of what they expected their baby to be. So it can kind of help that they know that, what's going to be coming. The impact, sometimes the type of defect, where it's located, can kind of make things easier or harder. Things that are very visible, like the face, or anomalies of the genitals that delay assignment of gender. So we have some babies will come out with like ambiguous genitalia where you can't tell if it's a boy or a girl. And that's obviously very hard on the parents. They don't know if this baby is a boy or a girl. They don't know what to tell their families. We have to do testing. We have to do ultrasound to see what their their internal, what do they have on the inside. So that's obviously not easy to deal with. Something that's fixable is going to be easier to deal with than something that cannot be fixed. But either way, right, it's just, therapeutic communication. We're never going to belittle, at least it's fixable, right? That's not helpful, right? They're upset. People kind of envision this perfect baby. They come out, there's something wrong. Just making sure that we're using language that is helpful and not making them feel, kind of bad about being upset. Right, so our communication, promoting bonding, right? We still want to make sure that bonding is happening. Sometimes it gets hard, when something happens and they don't expect the baby to be a certain way, it may impact that bonding. So really trying to encourage that. And then just providing them as much information as possible about whatever the anomaly is there a plan of care, follow-ups, and things like that. Perinatal loss, right? So we can have losses early in the pregnancy, and then unfortunately very late in the pregnancy as well. So can occur at any time, can occur in a high-risk pregnancy that you suspected something might happen, and can happen in a pregnancy that was going absolutely fine the whole time until this. So you really never do know. If it's an early pregnancy loss, so let's say first trimester, we don't want to diminish it's still horrible, right? But sometimes you want people to feel better about something, like, well, at least it was early. That's not helpful, right? So we don't want to diminish their grief. We're still offering support, bereavement. If they have a situation where it's a concurrent death and survival in a multi-fetal pregnancy, so one twin survives and one twin doesn't survive, that's such a complicated wave of feelings for the parents, right? They're grieving one baby, but they now have this new baby right in front of them. So it's very difficult for them. They still have to grieve that baby, right? So we still want them to go through the grieving process, but they also now have this anxiety of this brand new baby as well. They can have problems bonding with the living infant. They may receive less support from the family, right? Because people are going to say, well, at least you have this baby, right? So unfortunately, some people then feel like, oh, well, they don't need as much as we would if she lost, let's say, both babies, because at least they have this one baby. But obviously, they still need the same level of support. Our palliative and hospice care services, right? So if a patient knows that they're going to have a baby who is not, is going to be a stillborn, is going to be born with a condition where it's not compatible with life, like we know the child is not going to live, we want to offer like palliative care, hospice care to make the baby as comfortable as possible, right? Quality of life as opposed to extending it any. We want to minimize suffering, supporting the parents, and then just allow the parents to make the plan that they want, right? Asking them how do they want this to go, right? They're going to make the choices about the care, making memories, right? If they want to take pictures, like it really is a conversation to have with them and what they want out of the experience. A patient who's had a previous pregnancy loss, right, and now maybe has a healthy pregnancy, we want to take care of them too because they have this, probably PTSD from this last horrible experience they had. They tend to have very high levels of anxiety because of that, right? Even if it was like an earlier loss, once they sort of get to that part of the pregnancy with the next one, they start to like panic, right? Even to the end, they're just like, they're waiting for that bad thing to happen again, right? Sometimes we'll actually, like if we have a patient who had a fetal demise with the previous pregnancy, once they hit full term, they'll induce them for no other reason than just, we know the baby's alive right now at 37 weeks, induce and give this woman her healthy baby. Just because it tends to get so scary for them, especially at the end. So when we're talking about perinatal loss, right, whether the patient, comes in and to triage and says, I haven't felt the baby move, right, and I'm the nurse and there's no heart rate there, or she may come from the doctor's office where they told her there's no heart rate. That's the patient that we're talking about here, or it could be a patient who is in labor with a baby who's non-viable, right? She's in labor, we can't stop it, she's 21 weeks, the baby is not going to survive, right? How do we want to handle that patient, right? Before we go in to talk to the patient, we want to get as much information as possible so that we don't have to kind of bombard them with questions when we go in there. They've already answered the questions. Their nerves are shot. Like truly the last thing they need is you repeating the same questions. We want to acknowledge the situation and identify our role in the situation, right? Hi, I'm Debbie. I'm going to be your nurse today. I'm so sorry for your loss. I'm so sorry to be meeting you under these terms. What can I do for you? What would help you the most, right? Just so they feel like they have an ally in you. Initial grief responses, right? Crying, denial, anger, guilt, right? So you're really never gonna, you have to let them go through it the way that they're gonna go through it, right? So I've had patients who obviously crying, anger, and then I've had patients in full denial who were like, no, when the baby comes out, it's gonna be fine. I'm not arguing, right? That's part of their grieving. Like it does not help them to argue with them. You kind of just go through the process and let them do, kind of what feels right for them. We want to look at their support system, right? Who do they have with them? Is there any like religious, do they want a priest to come? Do they have somebody they want us to call? Certain services that may be helpful for them. we want to make sure that we're including both parents, not just the pregnant parent, right? Because they're both losing a child there. So making sure we're kind of watching both of them. And the two people may grieve differently, right? Which could be very complicated, right? One parent maybe doesn't want to see pictures, doesn't want to see the baby, just wants to get out of here. And the other one wants to do all those things. So it's a very complicated, kind of patient to have sometimes. And then in our follow-up care, right, we're looking for, kind of where they are at in the grief process, depression, PTSD, right? This is very traumatic experience they're going to go through. Anxiety disorders, panic disorders. So our nursing interventions, right, after, with a patient who has a perinatal loss, we're giving them time to express their feelings. They may want to be alone, or they may want you to just stand there and listen, right? So just making sure you're kind of offering that up. You don't want to be saying things to try to make it better, right, that are actually just going to make it worse. Make sure that you're listening. You want to acknowledge the infant and the rights of the infant. So the rights of the infant are on the side there, right? Be recognized as a person who was born and died, to be named, right? If we know the name, we're going to, when we're, kind of presenting them with the baby, use that name, right? Use that name a lot. That's the name that they gave the baby. Be seen, touched, and held by the family, right? So that's their right as well. What we do is we prepare the baby to be held by the parents, and we kind of give them as much time as they want with the baby. Have life ending acknowledged, right? So this was born and passed away. We give them certain things to go along with that. And then be put to rest with dignity, right? So we ask them what they want. Do they want to talk to, we literally give them everything. Like, here's options for funeral service. Here's, you can talk to this person. We get a bunch of social work. Everybody's involved, right? So we are going to allow the parents to talk about the baby as much as they want, refer to the baby by the name, allow the parents to hold the baby if they want to take pictures. Sometimes they come in with outfits that they want the baby to be put in. We're just going along with whatever they want. Presenting the infant to the parents, right? So this can be sometimes the hardest part, because sometimes the condition of the baby is really not good, right? So if the baby has been gone for 5 days before they noticed it, the baby's not going to come out looking like a sleeping baby, right? Unfortunately, things have started, the process has sort of started, so we have to we don't want to surprise the parents with that, right? We don't want them to be expecting a sleeping baby, and then we hand them this baby that looks, the coloring is off, they have, skin is peeling. So we we'll cover as much as we can, and then we just let them know. So we don't want them to be surprised by that. So we cover whatever we can. We're going to give them privacy. Some patients don't want to see or hold the baby, right? We want to respect their wishes and not make them feel guilty about it, right? So what we do, we want to give them the option. So we do like a memory packet with we'll do footprints of the baby. We fill out the paperwork just like we do in the hospital, like the name of the baby, the parents, the weight, so that they have these things. Some parents will say, I don't want them. We put them in an envelope, and we and we take pictures. We put them in the envelope. A blanket that we had on the baby, we'll put in the envelope. If they don't want to see it, we seal it and we give it to them. Because what was happening at Rumsey, at least, was if they didn't want it, we weren't doing it. And then 6 months later, they would come back and be like, do you still have those pictures? Do you still have those things? And we'd be like, no. So we started saying, listen, it's sealed. You can't see anything. Take it. 2 months from now, you may want to open it, right? So we kind of and other people are going to want to see it right away. So just really talking to the patient, and then possibly having to help them with other situations, right? Are there little siblings that have to be informed of? I mean, it's horrible. And then just providing them with all of that, that information. For the final, we definitely have to know our perinatal mood disorders, right? So we spoke a little bit about postpartum blues. So this is getting more into the depression and the psychosis, right? So postpartum depression is depression that takes place after childbirth and persists longer than 2 weeks, right? Those postpartum blues are the 2 weeks. Once we get to that 2 week mark, we're concerned. Typically, it's going to present in the first 3 months postpartum. It's the most common complication of pregnancy, with up to 20% of mothers experiencing it during one of their pregnancies, right? Screening for this is very important, and then teaching the patient, and probably more importantly, the partner, the signs of it, because sometimes if you're in it, you're not going to identify it in yourself, right? So it's easier if we kind of tell the people around her too, like, here's what to look for. Just be aware of it. Our signs of postpartum depression, anxiety, feelings of guilt, agitation, they can't sleep, they can't concentrate, they feel like they can't make a decision, crying, depression, less responsive to the infant, right? So maybe, they're not responding the way we would expect. The baby's crying and they're like not even hearing it, right? And then, if it gets bad enough, suicidal ideations, right? Unfortunately, we should be screening for this earlier, but generally that first time we're going to see a doctor postpartum is 6 weeks, right? So imagine how many people are potentially suffering with postpartum depression. And I mean, hopefully you get to the 6 weeks. So it's kind of crazy that no one is screening you until the 6 weeks. So it's really important that we're teaching the family to bring to our attention. So this is just one of our screenings that we do, right? If we had mom kind of fill out the screening and ask her about it. We want to make sure when we're talking to her that we're making good eye contact, right? Therapeutic communication, just to really kind of get an idea of, kind of like how it looks like she's doing, how she's answering those questions. Postpartum psychosis is a different thing, right? Postpartum psychosis, postpartum depression is also scary, but this is a psychotic episode that is very scary. It's an intense type of depression or a relapse of an underlying psychotic disorder. So if they had something like schizophrenia before, this would also be in there, but it could just be kind of a spin-off from that postpartum depression that is, it's an emergency. Severe mood instabilities that peak 48 hours to 2 weeks postpartum. So we're going to see this earlier. Again, this is a serious medical emergency, so this is not something that we're watching and waiting. We need immediate intervention. They may need to be hospitalized. They probably need psychotherapy and medications, right? Because they are at risk for, a bunch of things. But in addition to our postpartum depression symptoms, we're going to see possibly failure to be able to identify reality, right? So the one patient I could think of, she was young. She was like 15. Her parents brought her in. She was convinced the wallpaper was talking to her, like the Winnie the Pooh. Like she was convinced, and like we would have to go in there, and she was so scared of us. Like she would think like it would be a pen, and she'd be like, "You have a knife." Like she was just completely out of it. And like, a week before she was a totally healthy person, right? So it's very scary. Like she didn't have any underlying confusion, hallucinations, right? So the example would be Winnie the Pooh's talking to me on the wall. They may hear things, insomnia, hyperactivity, and then potentially much increased risk for suicide, homicide, and infanticide, right? Where they're gonna potentially kill the baby as well. Wow. It's very scary. So just remembering that if we see any signs of that, this is not a wait and see, let's see how she does in a week. She needs to come to the hospital because she needs to be like admitted and medicated.
4 is accelerations, right? So accelerations is going to be a short-term rise in the fetal heart rate. In order for it to be considered an acceleration, it has to last at least 15 seconds, and it has to go up at least 15 beats per minute above the baseline. So if our baseline was 120, it has to go up to at least 135, and has to last at least 15 seconds. It's a lot. I know. What we want to know about accelerations is that accelerations are good. We want to see accelerations. It's a sign of fetal well-being. It's a sign of a functioning fetal central nervous system. If we, let's say, had a patient, we looked at the baby, and all of a sudden we've noticed that they've been in minimal variability, a common question for the doctor to ask the nurse is, when's the last time we saw an accel on that baby? Because we know at that point, that baby was fine at that time. Like, that's how great an accel is. It's like, oh, my baby's okay, because we had an accel. The baby's able to do that, the baby's okay. So that's one way we can try to elicit an acceleration is fetal scalp stimulation. Right, so let's say we have a patient who has this minimal variability. Just like we could do ice chips, we can roll mom over. The doctor can try to do fetal scalp stimulation, where obviously water has to be broken, she has to be dilated enough, and the doctor will go in almost like doing a cervical exam, but is going in with the intention to rub the baby's head. they just rub the baby's scalp, and the baby should have an acceleration in response to that fetal scalp stimulation. Important to know, like, do not get this wrong, is we are not doing fetal scalp stimulation if the baby is having a deceleration, right? So the heart rate is down or the baby has bradycardia. We're not doing fetal scalp stimulation to try to bring it back up. That's further traumatizing the baby who's already in distress. We're only using this to see if we can get an acceleration on a normal heart rate, right? So a minimal variability normal heart rate. We're just going to kind of rub the baby's head to see if we can get an acceleration. So a deceleration is a temporary drop in the fetal heart rate. And we have a few different types of decels, and depending on what type it is going to determine what we have to do about it. So our first type of decel is our early deceleration. The way we're going to know that it's an early deceleration versus the other kinds is that it's going to mirror the contractions. So if we drew a line down, right, so there's our early decel. If we drew a line down from the lowest part of the decel straight down, it's going to line up with the peak of the contraction, right? So it's the contractions in the fetal heart rate are mirroring each other.
They're trying to touch each other?
I mean, if that's kind of the way, right? The lowest part of the decel is going to line up with the highest part of the contraction. So yeah, I guess you could say that. That's one way to remember it. So that it's mirroring. If you drew the line down, it's going to line up. That's mirroring. The cause of that is head compression. The baby's head is now nice and low. When mom is having a contraction, the baby's getting squeezed, right? That head is getting squeezed. Baby's heart rate drops. As that contraction relaxes, the heart rate goes back to normal. Early decelerations are our only good decel. The only one we want to see, because we want head compression. We want the head to come down, right? This is what we've been waiting for. So there's no interventions necessary for an early decel because it's good. Our late decelerations, right, so these are a problem. These are going to occur after a contraction, right? So if you drew a line down from that decel, it's going to happen after the contraction, right? It's late. It's late to the contraction. It's late to the party. It's a late decel, right? It's not lining up for us anymore. This is caused by placental insufficiency. So the placenta, for a million different possibilities, is no longer getting the baby the oxygen that it needs. Common cause of this is going to be after we give the epidural, mom has maternal hypotension. Mom has maternal hypotension. That's going to be less oxygen going to the baby. We're going to see late decels. We do have to do interventions for this one, right? So early, we're doing nothing, but we do have interventions that we need to do for a late decel. These are our interventions. We're going to reposition mom, usually onto her left side if she's not already there, to try to get blood flowing back towards the heart. We're going to put oxygen on mom to get oxygen to the baby, right? So we're giving mom oxygen in hopes that it gets to the baby. We can give her an IV fluid bolus, right? So we can open up her IV. If she's on Pitocin to cause contractions, we're going to stop it. Because we don't want to be giving her something that's causing contractions when the baby is distressed by the contractions, right? And we're letting the healthcare provider know. The way to remember it is lion pit, right? So see right next to it is lion pit. Left side, increase IV, oxygenate, notify doctor, Pitocin off, right? So just remember lion pit. Those are our interventions for late decel. Our variable deceleration, these are going to look a little bit different. They tend to be more abrupt, so they look more like V's than U's, right? The other ones kind of look more like a U. These are going to look more like V's because they're more abrupt, so V for variable. This is caused by cord compression. Baby's leaning on the cord funny, the cord is tied in a knot, it's wrapped around a foot, the cord is getting compressed. And we're going to see variable decels. right? So know that there's no relationship to the contraction. It has nothing to do with a contraction. You could have a variable decel with no contractions because it doesn't have to do with the uterus or anything. It's the cord, right? Mom could be walking around with no contractions and the cord could be getting compressed. So there's no relationship to the contraction. We're going to do our same exact lion pit stuff. The only thing that we would do a little bit differently with this one is because it's related to cord compression, we would want to probably do a vaginal exam as well to make sure the umbilical cord is not coming out through the cervix because that could cause cord compression. So we would probably want to do an exam as well just to make sure that's not what the problem is. And then our prolonged decel, exactly what it sounds like. It's just a long decel. Know that time period though. It's going to be considered prolonged if it goes from 2 to 10 minutes. So that's a very long time for the fetal heart rate to be down, right? After 10 minutes though, it's considered a baseline change, right? So we said when we're looking at a baseline, we're looking at 10 minutes. So if we have a patient whose baseline was 120 and now it's 70, for 6 minutes, we're having a prolonged decel. Once it gets to minute 11, her baseline is 70, which is, you never ever want to document a baseline of 70 on a baby. So by 5 minutes, we should be in the OR. And they will check that. Like if you have a situation, emergency situation that's related to a prolonged decel, they will go back into the monitor to see when you unplugged her from the bed. Like unplug the bed to go to the OR. Because if not, you're going to have to explain, well, why were you in there for 10 minutes watching this fetal heart rate? You should have been in the OR by minute 5, right? So by minute 5, we should be out of the room and in the OR. Once we get into the OR, we'll put the monitor back on the baby. And a lot of times, the baby's going to be back, right? The baby just wants to see what we would do. And then the baby's like, well, hold on. I didn't mean to do all this. Right now, the heart rate is back up, right? And we will wheel her right back into her room. But if not, at least we're there. If it's still down, we're at least starting the C-section, right? So that's the prolonged decel. We would do the same interventions right at the start, but just know that by minute 5, we should not still be watching this. That's just way too long for the fetal heart rate to be down. That's lion pit, right? The other way to remember it is veal chop, right? So veal chop, if you line up veal chop next to each other, variable decel is cord compression, early decel is head compression, accelerations are okay, and late decels are placental insufficient. So as far as our reproductive changes, this is, again, postpartum. Baby is delivered and out. We need the uterus to go back down to normal, right? The uterus had to grow, right, all the way up. You know, that fundal height had to go all the way up to, the xiphoid process. We need that uterus to start going back down. And that's called involution, right? So involution of the uterus. Spend the whole pregnancy growing, right, expanding and moving up into the body. We need it to start working its way back down, right? It needs to start shrinking back to its normal size. So that process is called involution. Our goal eventually is it's going to get back to pre-pregnancy size. This is going to begin immediately once the placenta is delivered, right? That fundus should immediately come down. Healing at the placenta site. So when the placenta separates from the uterine wall, it's going to leave a wound, an open wound, right, the size of a dish plate, like a dinner plate, right on the inside of the uterus. So that wound is going to be bleeding like crazy, right, because it's a wound, right? So healing of that site can take up to 6 weeks. That's why a lot of, in general, how long is lochia and discharge going to go on for? Around that time. That's also the reason why we tell patients not to have sex before that 6-week mark. It's because that wound is still kind of fresh and open. So that's the reason behind that 6-week number. So this will begin immediately once that placenta is out. What we want to happen, right, we can see in the picture, right, once that placenta is out and separates, we've got that big wound that's ready to start bleeding like crazy. We want the uterus to do what it does in that top picture, which is clamp down, right? Like contract down, and basically it holds pressure on the wound. It's holding pressure on its own wound, right? If it doesn't do that, right, it's just going to keep bleeding because that wound is just going to keep bleeding, right?
cause like hemorrhage.
Yes. So descent of the fundus, right? We want that fundus to start working its way down. Don't get too, honestly, the thing to know is that basically after delivery, we want it to be pretty much at the belly button, right? So don't get too caught up with it's 2 centimeters, because that's true, but generally just what you need to know is that after delivery, on that first day, like that first day of delivery, it should be at that belly button.
The fundus?
The fundus. And then over the next few days, it's going to descend 1 centimeter per day. So the day of delivery, if we're considering it to be, right at the belly button, the next day, right? So if the question is, she's 1 day postpartum, where do we expect to find the fundus?
Belly button.
1 centimeter below. Yes. If it's 3 days, it's 3 centimeters below. There's no math to be done, right? This should be an easy question. There is nothing confusing here. The same number of days postpartum is what it is how many centimeters below it should be. By day 14, generally it is now back where it belongs, right? Subinvolution, right? So the word subinvolution is when that does not happen, right? It's not going at the rate that we expect it to go, right? So it's a delayed return of the uterus to its pre-pregnancy size. That can cause hemorrhage, or could be a sign of hemorrhage if that's not happening. But we'll talk about that in the next chapter. After pains, right? Right, so that's the scenario that we're going to do first when we do the SIMS, then we run through the other ones more quickly. But uterine atony is the most common cause of early hemorrhage. So again, atony is the lack of muscle tone resulting in the failure of the uterus to contract. We need it to contract. The placenta separates, there's a huge wound that's just pouring out blood. It needs to contract on itself and hold pressure.
Where is it? Is it the white thing?
Wait, what do you mean?
No.
So this is the uterus, right? This here. This is the uterus, right? We needed to do what's in that top picture, which is kind of clamp down on itself,
I don't know.
right? But with atony, it's going to be that bottom picture. It can't clamp down. The uterus doesn't contract, and it just keeps bleeding.
Is that what causes the firmness? Like when we're checking for firmness, does that indicate that it's clamped?
That means we don't have uterus, right? If we check the fundus and it's firm, we don't have atony. If we feel it and it's spongy, it's boggy, we have atony. That's a problem.
It's probably liquid and blood.
So some of our predisposing factors for atony is going to be the overdistension of the uterus, prolonged or very fast labors, induction medications, especially with oxytocin, where we've had that uterus kind of really working hard for too long, retained placental fragments as well. If there's a retained piece of placenta, that uterus, especially the bigger it is, it's not going to kind of clamp down. Also, the body's still getting a message like, oh, there's still a placenta there. We don't have to clamp. The placenta's still there. What are we clamping down about, right? So it's that retained placenta can definitely be a problem. The way we're going to know we have uterine atony, right? The number one reason is number one thing we're going to see is a boggy uterus, right? That's a word to know because that's usually what is used in questions. So soft, boggy, spongy. It should feel like a rock. I mean, it should feel really firm. If the fundus is hard to locate, it's because it just feels spongy like the rest of the body, right? So it's hard to even figure out where that fundus is. If the uterus, we feel like it becomes firm while we're massaging it, but then the second we stop, it goes right back down, to being spongy. That's atony, right? The muscle can't maintain that tone. If the fundus is above the expected level, right, so we expect it to be 1 centimeter below on day 1 postpartum. If it's not, kind of making its way down, we're going to consider that atony is the reason why it's not doing that. Excessive lochia, right, so this is going to be excessive bleeding, hemorrhage, excessive clots. And again, the bleeding may be profuse or a constant steady trickle, both equally dangerous because there should be no constant bleeding. So definitely know your uterine atony management, right? What are we going to do, right? So she's delivered, that uterus is not firm, right? We feel it, it's spongy, it's boggy. We have something we're going to do prophylactically to try to prevent this from happening. So every patient, if you guys have been in deliveries, or C-sections, vaginal, doesn't even matter. Once that placenta is out, we start Pitocin, right? So you may hear them say, start the pit, right? Start the pit. we have a bag of Pitocin ready to go. When that placenta comes out, we open it. It's going to run in very fast to make that uterus contract. So if it was thinking about not, we're giving it a ton of Pitocin to try to get it to clamp down, right? So we're doing that for everybody. Whether they're bleeding or not, every patient is getting Pitocin. That's to try to prevent this from happening, right? So that's our prophylactic medication that we give. We can give that if we don't have IV access. Usually we do, but let's say the IV came out right at the end while she was pushing. We can give it IM as well, but generally it's going to be an IV. So let's say now we, yeah.
So it contracts, but it doesn't relax, right? You don't want it to.
At this point, we don't want it to. Like with the baby inside, we wanted it to be like contractions. This, we want it to stay firm and kind of clamp down. So now we check the fundus and it's boggy, right? It's spongy, it's boggy. The first thing we're doing, like I said, hand on the uterus, you're massaging. That is always the answer if there's a spongy or boggy uterus. Okay, we can call for help while we're massaging, but if our hands are already on that patient and we feel that it's spongy, we're massaging, right? The way that in that picture or in this picture, right? So always massaging if it's boggy. If it's not boggy, there's no reason to do it. Clots can prevent the uterus from contracting, so sometimes it just needs to work some clots out, and then that'll allow it to kind of clamp down. If the fundus doesn't remain firm from massage, or if the fundus is misplaced, right, so it's to the left, it's to the right, we're going to consider bladder distension, right? The bladder may be making it that this uterus can't do what it needs to do. There's no room for it because the bladder has kind of pushed it out of the way, right? So we're going to consider...
Because it's full, or
it's
because
full. Especially immediately postpartum, their bladder may just be filling up and they don't have the sensation, and the body's not going to kind of... So they may need to be straight cath, put on a bedpan, and kind of encouraged to try, because then they may not have that sensation. So we would assist with urinating catheterization, and then noting the urine output if it's displaced. So in a question, if any mention of it not being midline, you should think bladder, right? If it's midline, we're not thinking bladder, but if it's to the left or to the right, we're going to think bladder. So we had our prophylactic Pitocin, but if you guys come, we're going to go through all of these, and it'll be really good. We already gave our prophylactic oxytocin. If still, right, we're massaging, they got that Pitocin, that's not working, we can give them more Pitocin. Because really, that's our medication of choice, right? So we can give them more oxytocin. Usually that extra dose will be IM, but really it can be either one. If that doesn't work, right, our other medications, this is really a case where you need to know the medications, is Methergin. So that's another, all these medications do the same thing. They're all just trying to get that uterus to clamp down, right? So we gave more oxytocin, we can give Methergin IM.
Oh, wait. Which word is it?
The methyl
IM.
gonobin.
Oh, I see.
Yeah, Methergin. So the point of that, again, is to contract the uterus. Know the contraindication, though. It's going to increase the blood pressure, so if they're already hypertensive, we have to skip the Methergin. We can't give them Methergin. Okay. Cytotec, that's also, again, the same thing, contract the uterus. That's going to be a rectal suppository, right? So we put that in rectally. And then Hemabate is the same type of medication. It's just another IM medication that we could do. If the patient is open when this is happening during a C-section, they will inject it directly into the uterine muscle. Like they'll do that IM injection into the uterus.
I had a feeling the second you said IM, I was like, I really hope not inside.
Yeah, if it's a C-section and it's already right there, we open it sterilely and they just inject it right into the uterus. So that's acne, right? That's what we're going to do for acne. Oh wait, yes, I didn't go over the bottom. That's our medications for acne. Another thing we could try, which also looks very pleasant, is the bimanual compression of the uterus. So you're massaging from the top, and then you're essentially just punching straight through. Right, you're essentially putting a fist in, vaginally. So you're kind of like compressing. You're compressing it from both sides, right? From external and internal.
Normally you don't see this, right? I'm assuming.
This is like desperate times.
We don't.
This is really
The
desperate
doctor
times.
does that though, right?
I'm not doing that. No, this is
the
not a nurse.
Okay.
The other things that we can try in addition to that lovely picture is a balloon, right? There's something called a balloon where you go in and it would basically just internally inflates and holds pressure on the inside of the uterus.
Oh, there we go. That's
That
better. So
sounds
much better.
So the first one
Why
is
does that
the
even
picture.
exist?
Yes, that's the bimanual compression. Uterine packing, just putting, obviously you have to count how many sponges and things you're packing into that uterus so that you know how many to take out. And then further looking to make sure there's no pieces of placenta that need to come out. Last resort is going to be a hysterectomy, right? If everything we try doesn't work and she's still bleeding, they would have to take the uterus. So that does happen sometimes, but that is because we've literally exhausted everything. We've done all the things, all the pictures, and now that's the last resort. So that was atony, right? So that's one cause, right? Another cause is trauma.
So newborns can't shiver, right? So adults, older kids can shiver when they're cold, right, to try to produce some heat. Babies cannot shiver. So what they have is non-shivering thermogenesis. So this is how they're going to produce heat for themselves because they can't shiver. So one thing to notice, right, when you're doing questions, any mention of a baby tremoring, they won't usually use the word shiver, but shaking, it's usually not going to be that the baby is cold. There's something else causing it, right? Because babies don't shiver because they're cold. So remember that. It's a good thing to remember when you're doing questions. So cold babies become restless and cry, right? That's going to increase activity, which is going to produce heat. And then they have their non-shivering thermogenesis, which is where they're going to metabolize brown fat. They have something called brown fat in those areas. So on the baby, it's where the purple is. And the purpose of that brown fat is for it to be metabolized for heat. It stores energy and helps regulate the body temperature. So this is another reason a preterm baby is going to be at risk for, poor thermal regulation, is because they don't have as much brown fat as a full-term baby, right? And that's what they use for heat production. Why we're concerned about a baby getting cold, like it's not just, because they're going to be uncomfortable. No, cold stress can actually cause a lot of issues for a baby. So increase O2 needs, right? So if they're cold, it's going to increase their need for oxygen, which is going to put them at risk for respiratory distress. It can decrease surfactant production, like I just said, respiratory distress. Hypoglycemia. So what can happen if a baby is cold? The body's going to start using the glucose to burn off for heat, and now the baby is hypoglycemic. So when you see those questions mentioning that the baby is looks like they're shivering, they're shaking, they're tremors, a lot of times it's actually hypoglycemia that's causing it. Right? So the cold stress caused the hypoglycemia, and now they're shaking. Metabolic acidosis, jaundice, so it puts them at risk for a lot of different things. Our early assessment of the baby's head, right? So molding is normal, right? That's where the baby's head is, the cone head, right? When they're born with vaginal delivery, they look like little cone heads. That's normal, right? Their sutures are sort of meant to kind of go over each other to fit through. So molding is going to resolve itself usually in a few days. We could say up to a week if they were really, really cone heads. We have our fontanelles, right? The anterior and the posterior fontanelles, right? So that's these things right here. We have the diamond shape here for the anterior, and then the posterior is that little triangle in the back. Know about your fontanelles. They come up, right? So the anterior fontanelle, the one in the front, the bigger one, that's going to close by 18 months of age. And then the little one in the back is going to close by 2 months. So these are the soft spots on the baby's head, right? When you let your child hold a newborn, you're like, don't touch their head, right? It's because of these two spots, right? Because they kind of haven't closed off yet, and they're just the soft areas on the head. If we notice that the fontanelle was sort of like sunken, they should be flat, right? You should feel them. You could feel that they're softer than the rest of the head, but they should be flat. If they're sort of sunken in, we're going to think dehydration. If they're bulging, we're going to think either increased intracranial pressure, overhydration. And then we have our caput and our cephalohematoma. Know the difference between these two, right? That's really mostly what the question is which one is it? The caput is the one that's, you know, you can see where the name is there, right? It's a localized swelling of the infant's head. It crosses the suture line. So it's not just staying in one spot, it crosses over the suture lines. Right, so you can see that one, it looks more uniform than like the one, you can kind of really definitely see that second one. Crosses the suture lines. This will generally resolve in 12 to 48 hours. This is just from labor, from birth. And then the cephalohematoma, that's the one that's closer to this way. That's a collection of blood between the periosteum and the skull. That one doesn't cross the suture line. So if you look at the picture, you could see it kind of, you could tell it doesn't cross over. It's very defined in comparison to the other one. This one can take a little bit longer. This can take up to 3 months to fully go away. And it's going to increase the baby's risk of jaundice, hyperbilirubinemia, right? It's going to increase their risk of jaundice because it's a collection of red blood cells. And when we talk about jaundice, the breakdown of red blood cells is what's going to cause jaundice, right? So they're going to have an increased risk because they have that collection there. Like we said, we want the baby to be in. So all of our different reflexes, right, know these for next week. I know if any of you who are in clinical, right, you test these, right, you test these babies, right, the Moro reflex or the startle reflex, that's that top one, right, that's the one that looks crazy because it looks like we essentially pick the baby up from by the hands and then drop them, right? So that's how we test that one. We pick them up a little bit off the bed, we drop them back onto the bed, and they should have like this, their arms should sort of come out and fan out. That's the startle reflex. Loud noises will do that too, right? So the baby will just do this, right? A newborn just all of a sudden will be like, over anything. It could, another reason that we want to watch it is because if they don't have that reflex in response to something loud, it could be a hearing issue for them, right? It could be that they can't hear it because they should sort of have that reflex. So that's the Moro reflex. The Palmar-Grass reflex, that's the cute one, right? You put your finger in their hand, they're going to hold your hand, they're going to hold your finger. Palmar-Grass, we just kind of push a thumb under their toes, they should curl down. Babinski reflex, we're going to kind of scrape under their foot a little bit. In that motion where the arrows are, their toes should fan out. The rooting reflex, right? So rooting reflex and sucking reflex is what we need for them to eat successfully, right? So rooting reflex, if we sort of just stroke their cheek, they'll turn their mouth towards that direction. Sucking reflex, right? We could test this with a gloved finger, with a bottle, with if mom's going to breastfeed. Just they should have that reflex to start sucking on whatever's in their mouth. And then the tonic neck reflex, they're going to have this fencing position, right? If you put a baby down, right, they'll kind of get into this. And then the stepping reflex, right? That's another fun one. If you hold the baby up, it'll look like they're trying to take steps, right? And then the parents like, oh, they're so advanced, they're so smart. They're trying to walk, right? So that's another cute one where they try to walk. This just kind of goes through them. Our biggest concern, again, is respiratory, right? So asphyxia is going to be one of our big concerns, insufficient oxygen and excess CO2. If we keep this going, right, we don't fix the problem, it's going to lead to damage to the organs, right? There's going to be ischemia to the organs. All of these things are going to put a baby at risk for this. Really more mom, like if mom has like any hypertensive conditions that we're going to talk about at some point, placental issues, if there's an infection going on, right? There was chorioamnionitis, and now the baby has an infection as well. Drug use, umbilical cord problems, preterm babies. If we gave narcotics shortly before birth, right? We spoke about how that can depress their respiratory system. So our manifestations of that, right? What's going to happen first is our primary apnea, right? So the baby comes out, they may have this sort of rapid, frantic breathing, followed by they just stop, right? They stop breathing. What we can do to get out of primary apnea is what you see pretty much everyone do during a delivery, is stimulation, right? So tactile stimulation. We take that blanket, we give them a nice little back rub. The point of that is to get them out of that primary apnea, right? It kind of stimulates them to start breathing, right? So primary apnea will respond to that tactile stimulation. If it doesn't, then we're going into secondary apnea, where they may have like gasping breaths that eventually stop altogether. We're going to see a drop in their SpO2. The baby will lose consciousness. Stimulation will not work, right? So remember that in general for the test as well, right? Primary apnea, we may be able to use tactile stimulation to get them out of it. Once we are in secondary apnea, no amount of rubbing the baby's back is going to get them out of that. We have to move on to our next thing, which is going to be our positive pressure ventilation, right? So primary tactile stimulation, secondary positive pressure ventilation, right? So that's the little ambu bag that we're going to use to just kind of jumpstart their breaths, right? So once we know we're in second, we should be moving on to the next thing, right? We need them to initiate that those respirations, right? So we're going to go into our resuscitation mode, and that's what our positive pressure ventilation, which is the little ambu bag. Sometimes you're literally just going to pump that little bag one time, and it just kind of like gets everything started. The baby's like, oh, this is what I'm supposed to be doing, right? So it is very effective usually. So we're going to do our positive pressure ventilation. If a baby really needs to be resuscitated, right, we're doing positive pressure ventilation, and then we're, God forbid, things get worse, we're doing CPR. While we're doing all of that, we need to also be mindful of their temperature, because they could be in cold stress. Like, let's say our warmer's not on. We're so busy worried about this, but if we then put them into cold stress, it's making everything worse, right? It's going to put them into more respiratory distress. So we do have to make sure that we're being aware of their temperature while we're resuscitating them. With newborns, the answer almost, if we have a baby who's not doing well, the answer is almost always a respiratory problem, right? So if we're walking, out here and somebody collapses in front of us, it's an adult, we may think cardiac, right? You may think of like jumping to CPR, right? With a newborn, it's almost always a respiratory problem, right? So the positive pressure ventilation is going to be the most important thing you can do, because a lot of times that's all they need. If you do get to the point where you need CPR, which is like 1% of deliveries will result in CPR, things are very bad, because the respiratory things should have really worked. So if you make it to CPR on a newborn, you're very concerned, because that really shouldn't be the issue. We just want to make sure we have all of our equipment ready for any kind of resuscitation. That's going to be really important. As the nurses, that's part of our responsibility, to make sure that we have everything we need to resuscitate a baby. So just some of our, definitely know your two different types, right? What's the difference between the two? Our physiologic jaundice is our normal jaundice, right? It's not going to be present in the first 24 hours, right? Know that timeline. We will not see physiologic jaundice in the first 24 hours. Generally, day 2 and 3 is when we're going to see this. Most of the time, this is actually going to fix itself, right? Baby needs a little time to kind of work out the red blood cells that are responsible for, getting the breakdown of red blood cells is going to release bilirubin. We need the bilirubin to leave the body, right? So we need the baby to have some more stool to get rid of that bilirubin. So generally, this is something that will fix itself once the baby starts eating more, putting out more diapers. 10% of babies are going to need phototherapy, right? They're going to go under the lights that you may have seen in clinical, right? So that's our normal jaundice. Non-physiologic jaundice is not normal. This is the problem. This is going to occur in the first 24 hours, right? So again, know which one is which. It's going to occur in the first 24 hours. It's caused by some kind of abnormality that's going to result in the excessive destruction of red blood cells, right? So whether it's the baby just has too many red blood cells and now they all have to, they kind of break down. But it's too much bilirubin. They're going to rise faster and higher than with the physiologic, which is our normal, right? Know your common causes of this, right? Like, why would this jaundice happen? It's most of the time going to be related to an RH, or ABO blood incompatibility, right? So mom is Rh negative, baby is Rh positive, and it's going to cause this type of jaundice, right? So just know which one is normal, which one isn't. Can lead to bigger issues, right? This is always going to be treated with phototherapy. So our bad jaundice, right, is related to Rh incompatibility. These are the two tests that we can do that are related to this. So we can do an indirect Coombs test, which is a blood test that's given to the mom while she's still pregnant. That's going to let us know that there's antibodies that are going to go against the baby's blood type, right? So that's a test we can do during the pregnancy to let us know that this is happening. We can also do a test after on the baby once it's delivered. That's the direct Coombs test. So that's a blood test given to the baby that's going to identify if antibodies have attached to the infant's red blood cells, right? So those are the two blood tests that we could do that are related to that bad jaundice, right? That Rh incompatibility. Know which one is during the pregnancy, which one is to the baby. So what are we going to do, right? Our phototherapy, right? So with the physiologic jaundice, 10% of the babies are going to need that. With the non-physiologic jaundice, they're all going to get phototherapy. It's our most common treatment. The way that it works is the bilirubin in the skin gets absorbed by the light, changes it into something that is more soluble that the body can get rid of. When the baby is under the lights, right, we want to make sure that their eyes and genitals are covered. All other parts of their skin should be exposed, but the genitals and the eyes should be covered. We want to turn and position the baby, right? So the baby is not kind of stuck in that one position. We want to turn and position them because of the risk of skin breakdown, but also because we want that light to get all the skin, right? We want that light to end up kind of touching all parts of the baby for it to really work the best. We're watching skin temperature, avoiding cold stress and overheating. We're assessing them for hypoglycemia. Feedings are still going to happen during this, right? So we're still feeding them, obviously, but breastfeeding can also still happen during this, right? Just a reminder, we spoke about it last week, right? Breastfeeding is sort of a risk factor for jaundice, right? Because the babies are going to put out dirty diapers kind of later than a formula-fed baby. Formula-fed baby is right from the beginning, getting a certain amount of formula and then putting out diapers. Breastfed babies are going to start getting milk a little bit later. Mom's milk has to come in. They put out less stool diapers, but we're never telling mom not to breastfeed because of that, right? So mom can still breastfeed, and the baby would take breastfeeding breaks from the light. Two of our side effects, right? So normal side effects, like we're not concerned if these things happen, would be diarrhea and macular skin rash, right? Like sort of like a red rash. The way we're going to check for jaundice, right? First of all, you may just notice it, right? That they may look yellow. We're going to kind of push on, over a bony area and observe the color. If the child has darker skin, where wouldn't be super noticeable on just their skin in general, we want to look at the sclera of their eyes, the hard palate of their mouth, mucous membranes. Infants born to diabetic moms. The biggest thing that can help a diabetic patient, have a baby who does not have complications is just having a well-controlled diabetes during their pregnancy, right? Keeping up with the plan, checking their blood glucose levels, trying to keep things as stable as possible. Macrosomia is going to be our big risk thing when we talk about a diabetic mom. They tend to have very big babies, but again, it's really more with how well controlled the diabetes is. You can have a normal sized baby with diabetes, especially if you're really well controlled during the pregnancy. We are worried about hypoglycemia after birth, right? So hypoglycemia, the baby will have excess insulin produced to respond to mom's excessive glucose during the pregnancy. Now the baby is out and does not have that excessive glucose anymore, but it still has all this insulin. So a diabetic baby to a diabetic mom, we want to check them for hypoglycemia. What are we doing? Right, we're going to watch the baby for hypoglycemia, right? Any shaking, tremors is the most common sign. We're going to check their blood glucose. Again, normal, we spoke about this last week, normal is between 40 and 60. And if we get a result of between 40 and 45, we want to tell mom to feed the baby first, and then we'll retest it. We're looking for signs of respiratory distress, again, because it's related to low glucose.